If you want bells and whistles on your toothbrush, this isn't for you. Toothbrush brands love selling you gimmicks, Bluetooth, an AI app, and 6 brushing modes. Who asked for all this? And what you really get is bad battery life, bulky design, jarring noise, and lots of plastic. You don't deserve that. Neither does the planet. At Suri, we focus on what actually matters. A brush that's engineered to do one thing exceptionally well. Give you a cleaner, healthier smile every time. No gimmicks, no hype. Just a powerful sonic clean and things that actually make your life better. Like a brush you can travel with, a 40-day charge, a UV sterilizing case to keep your brush clean, and a whisper quiet motor for a peaceful wind down. And of course,
You're welcome. Hello, everyone, and can you believe it? We are here at PerfWeb 104, last day. I don't know exactly how many weeks we have completely destroyed our scheduling, and we have, I know, created a tremendous amount of complication for many of you out there. I have gotten all of these emails. It has been it's been a challenging time for me. Very, just tell you now, I'm not going to get into any details of anything, but there were certainly some things that resulted in all of these scheduling conflicts. It's fully my personal responsibility. It's my problem, and I'm going to make it right for everyone. I've sent off a little message on the YouTube chat format for you all to look at. But for anyone affected Obviously, this is still June, and just so you understand how the board works. And by the way, hello.
Hi.
It's good to see you.
Good to see
Samir.
you.
Very nice.
Good to see you.
So you all know, as long as the PerfWeb began before June 30th, or on June 30th even, then even if it went into July, it still counts for June. So it's when the program starts, not when it ends. So everyone's going to be okay as far as their credits are concerned. But I also understand that some people had made plans and they were ready to do this, and that required you to change your plans and maybe even time off and things like that, which I sincerely apologize for. But we're going to make that right. And for those that are affected, or were affected, we are going to give you something, some programs for free, a discount on your yearly subscription, whatever the case may be. Also, this is our last program in this studio.
Yeah,
this
exactly.
is the final program in this studio.
Right.
We have a new studio that we will be closing on Wednesday, and then it's going to take about a month to get everything in here moved and over there. That part's the easy part. It's then going to be mostly it's deconstructing all of the wires. There's so many wires, it's not even funny. It's crazy. And then reattaching all of those wires over at the new place and making sure everything actually works. So you could just imagine, I could push it and say, you know what, we're going to have it up and running in 2 weeks. But if I did that, then we're not allowing for both David and Magic to really test the system and make sure everything's going to work.
Yeah.
But the new studio, and I welcome anybody that wants to come here to Houston to come see it. It actually is a studio. It's built, well, its purpose is a studio.
Studio, right, okay.
This is a converted garage.
Correct.
And bedroom, right?
Right.
And so it's not really, the new place, it feels like it is built, it's designed, it's constructed, everything about it
Screams
is
studio.
For a studio, right.
Right.
It's actually something that would be easy to rent out to people to use as a studio if they wanted to. We don't plan to do that, but we could do that.
Right, okay.
Because that's really how it's made. It's made for that purpose. It could accommodate any kind of audio visual kind of thing that you want to do. You could do virtual. We have an enormous green screen there, lots of room for doing simulations. You need to come by and see it.
Yeah, I want to see it.
Yeah, and hopefully you should see it before we put everything in it.
I would hope so too.
Yeah, you need to do that. Let's do that. Let's do that this week. I think we'll have an opportunity to do that this week. Say again? We have a walkthrough on Wednesday. Yeah, because I'm closing on Wednesday, as a matter of fact. But anybody out there that may want to come and go to it, I mean, you are absolutely more than welcome to. I think you would enjoy it, and to see what this studio really looks like from the inside. And even get online with us. We'll put you up here at the desk. I'll get the balloon. I'll get the balloon patient out, and we'll try to kill the patient. We'll do some stuff like that. So that should actually be a lot of fun. So with that said, we are going to be changing the schedule here today. The first one we're going to talk about is the one that's scheduled for 5 o'clock: comparisons of professions, salaries, work schedules, educational requirements, and responsibilities. How does Perfusion compare? And I've got some interesting articles and things. I did a lot of research on this, reading, and I've got some really good sources to use for us to kind of look at this and compare. What is it? What is our job really like in terms of its requirements, responsibilities, work hours, and pay compared to other things, other people out there in the world, right? Different industries, comparing it not just to other medical professions or disciplines, but also comparing it to non-medical disciplines, because there's some really very interesting differences. And I have some perspective, and of course you probably are going to have some perspective. My perspective is, I wish I could make all the money that I make and never have to go to work a day.
Gosh,
that would be great, wouldn't it?
That's the dream.
Just to get paid, to just sit around, and that's it. Yeah, that would be really nice. And the second talk is going to be, whose responsibility should it be to report or dismiss an obviously inept physician, surgeon with, I guess physician and surgeon
Are the same.
right?
Yeah.
Surgeons are physicians first,
Yeah.
or any provider. Okay, whether it be nurse practitioner, physician's assistant, perfusionist, nurse, you name it.
Yeah.
And I think that that's going to be a very interesting conversation, and hopefully we will have a guest speaker who will come on via the telephone.
Okay, great.
About that. And then the last one we're going to talk about is the perfusion staffing crisis over?
Okay,
And
good.
if so, what will be the consequences? Now, in that particular thing, I'm going to have Debbie Adams, who is the program director at the Texas Heart Institute. As you know, Texas Heart Institute was the first accredited, organized, if you will, perfusionist training program in the world, really, but in the country for sure, but I believe in the world as well.
Okay.
And the program I went to was the second. I went to THI2,
Okay.
which is the Tucson Heart Institute. It was named THI
No.
because the guy that trained me, Billy Applegate, was very, very good friends, real close friends with Charlie Reed.
Right. Who
And
was-
so they had, Charlie was going to start that, and he really wanted to start his program. Charlie was like, well, I'm going first, and it's going to be the Texas Heart Institute, so we're THI. He says, I think you should be THI too. And he says, but we're not. I don't think our hospital's named it. Any of our hospitals that matches. He goes, it's Tucson. Billy, it's Tucson.
Yeah.
Oh yeah, that makes sense.
Yeah,
So
yeah.
I've heard the whole story. I kind of knew the whole story. I was the second person to go through the program.
Oh, wow. Okay.
I was the second person to
Oh,
go through
pioneer.
the program.
Wow.
Yeah, second
Yeah.
person to go through
They
the
used to take
program.
one at a time back then, right?
They did one
Yeah,
at a time, yeah.
right.
And it was mine was 2 years, and you were on call for the entirety of the 2 years.
Oh, my gosh.
You started your first day, and you were never not on call for any reason whatsoever. Not a holiday, not a vacation, not children being born. It did not matter.
Right.
You are on call, and you are expected to be where you're supposed to be when we tell you to be there, and that is it.
Wow.
And we did a lot of cool stuff.
Sure.
I got to see a lot of stuff because
Right.
when you're in that environment, you see so much
Yeah.
just by the mere fact of being exposed, being required to be available.
Right.
And that's kind of the thing that goes on right now with training of physicians and everybody else. There's this work hour requirement, and
yeah.
they don't come out having seen nearly as many things
no, they don't.
as they saw before.
Yeah, they don't.
They
They
just
don't.
don't. It's really
Yeah.
and so it's a double-edged sword.
Oh, yeah, absolutely.
And I don't know which is the right answer. I don't really know.
I mean, I did my residency in India, and they obviously don't have no work hour restrictions.
No.
I was there all day and night.
Yeah,
Like
yeah,
for days on end.
yeah, for days on end.
It would
yeah.
just be like 5-6 days in a row
But
where I
you
wouldn't even see
saw
my house.
things that you would not have
Oh, yeah,
ordinarily
that's what I'm
seen,
saying.
right? And a lot of it. In other words, by the
Yeah.
time you were finished, things you didn't ever get in a situation where, well, I've never seen that before. No,
Exactly.
I've seen this 100 times.
Exactly.
And so your
yeah.
decision-making algorithm is so much easier that way because
Right.
you've seen it.
Yeah.
But then look what it does to you.
I was just
It
about to
makes
say,
you like
there's the
you.
other side,
Yeah, right. What does it do to what does it do to any of
On
us?
day 5 of being there
Mm-hmm.
for 5-6 days in a row, I don't know if I was making the best decisions.
Well,
you
no, but I think
know?
it changes you as a person.
It did.
I think it does. I
And
think it.
it makes like doing an 8-hour, 12-hour shift like a cakewalk,
Yeah.
It's so easy.
It's all perspective.
It is all
really
perspective, right.
I've had jobs before where it was just nonstop work,
Right.
and then went and took a job somewhere that was, a couple of days a week maybe, and
Right.
I'd be like, what the hell do I do? Like I almost didn't know what to do with myself. And
Right.
I actually got depressed at one of those jobs where I was like, I'm bored stiff, but you were on call. You couldn't go anywhere.
No, right? Yeah.
And so you were like, well, I can't really do anything. I mean, what's worse?
Yeah.
I'm
I
not
see
sure
what
what's
you're saying.
worse here,
Being at home knowing you can't do anything.
Yeah.
So then it's almost like you're not at home or because you can't have leisure time, right? Like
Exactly.
there's no
Exactly.
Yeah.
Well, work originally had 2 Ks,
Okay.
but they wanted it to be a 4-letter word, so they just dropped one. So anyway, with that said, and we're gonna Debbie's gonna be on the call,
Okay,
and
great.
then we're gonna do the So that's going to be the third one. Oh, the third one, right, is going to be the Perfusion Steffing. Right? That's with Debbie Adams.
Right.
Okay, you want to do the opening remarks real quick? This is the last time here at our studio. We'll just do it real fast. So if you want to reach out to us, you're going to have contact at perfusioneducation.com. We do get those emails. We do read them. I've already told you that I do. Don't always respond to them as quickly as I should, and at least I have it over the past few weeks. But I look pretty good, right? I still look good.
Yeah.
I still look good despite all these issues. But getting old just sucks. You know, it just really does. Anyway, contact us at perfusioneducation.com right there. And then we used to have a phone, and I'm going to bring back the damn phone. I'm going to tell you right now,
It's coming back?
bringing back the call-in number.
Yay.
All right? I'm sick and tired of this, and I'm going to pay people to just call us nonstop. I want the phone lines. I want multiple lines with all the lights lit up. Okay, that's it. But anyway, you see our scroll bar down there. They call it a chyron or a crawl or whatever it is. You can just look at that. It's up and down intermittently throughout the day. On the social media platforms like YouTube, Place, what used to be Twitter and now is XYZ, and then you have LinkedIn or LinkedIn or whatever that's called. Please do me a favor. Like, subscribe, share, thumbs up, ask for notifications, all those things that you need to do so that those platforms will continue to move us up the ladder. And again, when we do this, studio is awesome. I really can't wait till you see it. I'm going to show pictures of it. I'll send them out to people on our mailing list and stuff so they can see kind of what's going on. Okay, and then next is our app. Wrong way. If you go to the either the Apple Store or the Google Play Store, you can find it. It's under MediWeb. So it is a perfusion and critical care app, and there's a full app which has everything in it. It's $2.99. Get it while it's still $2.99 because I'm going to go up on that price. And then also there's a standalone app which is just the IV rate and dose calculator. It's very, very good. I think you would really enjoy that app, and I think both of them are useful. You get that IV rate calculator in the full app, but you can buy it separately, and it's only 99 cents. I'm going to go up on that one too because that's a really good app actually. Okay, next end is our podcast. You could go to Spotify, Podbeam. Any of the things that you may, whatever your podcast platform of choice is, type in PerfWeb, and you can listen to us banter back and forth and discuss things, which is going to be predominantly what we do today. Right. So I would go there and look at the podcast. All right, I think that's it, right? Last thing? Perfect. So let's just dive right into this.
Okay.
And I have YouTube up. Oh, I have it up, but it's
Muted.
no, it wasn't muted. I had my computer muted. Is that better? Okay, I'm so sorry. So let's start off with this. I hate specialty care. God knows I hate
you
them.
really do.
I do. They are my mortal enemies.
Yeah, you really.
Okay,
Yeah.
but they do have information.
Sure.
And now some of it I think is a bit exaggerated, but that's okay. We'll kind of get into that a little bit as we go. But they want to have that perfusion careers. 60% of Americans are projected to have heart disease by 2050, and they're leading the industry in perfusion. So in perfusion careers, that's probably true. To be honest with you, they probably have, I would say, 30 to 40% of the market share.
Yeah, they have a lot.
They have a lot. I think they're bigger than Comprehensive, but Comprehensive has been a conglomeration of several different companies that kind of became what they
Specialty
are.
care is still number one in.
They are. I
Yeah.
think they may be too. But this is the part that I thought was going to be interesting, and I should have probably highlighted. Here it is, right here. Well, let's just look through it all.
Okay.
The American Heart Association released a published report projecting 6 in 10 Americans will have some form of CV disease by 2050. This projection comes from worsening trends related to important health factors such as diet, exercise, sleep, and maintaining healthy blood pressure, body weight, blood sugar, and blood cholesterol. Now, with that said, they obviously wrote this before RFK Jr. got involved.
Right.
Because I think there's a real push to change that. But that would be a different topic. I realize that. I don't want to get into something else here. And the report is also based on demographic shifts in the American population as more people age and the population becomes more ethnically diverse. Minority groups, including Black, Asian, Hispanic, and Native American populations, tend to have higher rates of CV disease risk factors, and these heightened risk factors also found among Americans living in poverty. I think that's a political statement. I'm not going to get into that as well.
Sure.
So let's just move off of that and talk about how specialty care is rising to the challenge. Now, this I think is important, especially the second paragraph. The demand for perfusion services will continue to grow based on the growing rate of cardiovascular, respiratory, and chronic diseases, the need of the aging and diversifying population, the increasing frequency of organ failures and transplants, and innovations in the surgical field. Now, I'm going to just dissect this a little bit and I'm going to get your opinion on it as well. First of all, I think they missed completely the real reason why the demand for perfusion services will grow.
Okay.
And I think it's not because, I don't believe it will be because of the growing rate of cardiovascular disease, because I think I think this country is on a pathway right now to try and fix that. I think there's a true appetite in the government to do something about what we are basically poisoning our children with.
Sure.
And developing these very, very, very bad habits. But cardiovascular diseases, respiratory diseases, and chronic diseases, are they going to grow? I don't think they're really going to grow. What I think is going to happen is I think we're getting so incredibly good at doing ECMO, not necessarily doing that much better in outcomes with ECMO, but certainly the amount of ECMO we are doing is on the rise tremendously. So that's one. Expansion of what's not on here, expansion of existing services.
Correct.
But increasing the types of services that perfusionists are involved with,
like NRP
is
and things
like NRP,
Right, yeah.
and what there will be after NRP,
Right.
because there will always be some form of extracorporeal circulatory type therapeutic modality that is going to be used.
Correct.
We don't know where it's going to go, but it's going to go somewhere. And I think that what they said here, though I do believe the need for perfusion services will increase, I think they were correct in that statement. However, I think they missed the boat on why.
Right.
They could have left all of this in if they wanted to, but they should have added to it.
Right.
That's what I think.
Yeah.
So expansion of existing services and vis-a-vis ECMO in particular, and also introducing additional types of services.
Right. I think I agree with you there. I mean, especially with regards to the prevalence of chronic diseases, cardiovascular and respiratory diseases going down. We're just more aware nowadays. We do a better job at screening. We do a lot of stuff that's a little bit better. It's not like before, now people know what trans fats are. They know what to stay away from, and so logic would dictate that the prevalence will go down as time goes on, right? Like as awareness goes up. But yeah, I mean, I agree with it. It's going to be new lanes. Yeah. It's not going to be the same lane getting bigger. It's going to be, we're going to just have so many more avenues to go down.
With the exception, I think, of ECMO.
Yeah.
I think that lane is going to expand.
Yeah.
I think you're going to see.
I think it's already expanding, like you said. I mean.
Well, I think it's going to, see, this is the problem. And of course, it's a separate issue. But it's still an issue. We have to look at David, I'm so sorry. Please forgive me, audience, but
Just
you
at the
really needed
time.
to get that clock battery changed, didn't you?
He didn't like it that it wasn't
That was
working.
really, you know, everybody's got their neuroses. You make fun of mine, but you know, I'm not going to say anything, David. I'm just going to let you have your clock.
He has all this important work to do back there, and
That's our show clock. And you're right. And of all things did not work today, of all things to not work, the show clock, that's number one.
yeah, our show clock is a wall clock, by the way.
It's a big, yeah, it's a big
that's right,
it's a
right in front of
big,
David's face. So
old-fashioned
he
wall
can't help
clock.
but see it.
He's just praying for that thing to spin around. He's wondering why it doesn't move faster.
Right.
Yeah, like in warp speed or something, right?
Exactly.
Yeah, can it be like I did interstellar
Yeah.
transport?
Oh yeah, exactly.
Yeah, but you know, so expansion of those services, I think, and of course, you know, as that happens, if the expansion outpaces the number of available clinicians, what happens?
Right.
You start like we did with auto transfusion, cell savers.
Mm-hmm.
We didn't want to do them.
Right.
This is bullshit. I'm not going to do these cell savers. We're going to let's get somebody else to do these.
Yeah.
And somebody will.
Yeah.
Simple as that. Somebody will do it.
Yeah, I mean, the
You know?
ATs were born, the
Right.
PBMTs were born.
Right,
You know,
right.
we got all kinds of new people coming along that want to
Correct.
do it.
Correct. And so, you know, these are the kind of things that you're going to see. Excuse me. Please forgive me. But nurses as ECMO specialists, which I still feel that nurses are better equipped than respiratory. Not always. I don't think every nurse is a better, just automatically, a better ECMO specialist than any respiratory therapist. I think there are some exceptionally good respiratory therapists that can compete with a lot of
Absolutely.
nurses, but they're not trained for it.
No, right.
And those people have to have taken the extra step to learn.
Right.
Conversely, you can have nurses, you can have perfusionists, you can have physicians who just they're just apathetic. They don't care. It's a
Yeah.
job. I got to do my job. And they do it to the absolute minimum standard.
Right,
Right.
right.
And so, you know, with exceptions excluded, perfusionists, if this ECMO grows too fast, too much too fast, we're not going to be able to keep up, and we're going to have an outlet, and that outlet
Right.
will eventually absorb all of it.
Right.
That's very possible to have happen, and that's the double-edged sword that you sort of have to
Correct.
watch out for.
Yep.
And that's where you get into the issue of licensing. I mean, for Christ's sakes, how many fights have we had about licensing? Oh, we would need to protect our jobs. Perfusion is not in the scope of practice of nurses. Well, I mean, so ECMO is,
Right.
right?
Yeah.
So-
which is a pump. It's almost the same thing, just missing a
Right.
few key ingredients. Other than that, it's
Yeah, but the main
main stuff's there.
thing is there.
the heart
right?
and the lungs are there.
Right. And so, we have this issue with what is the right direction to go? I don't have the answer.
No, right.
I wish I did. I'd be really smart and probably people would actually pay for my opinion. But I do certainly see the challenges.
Right.
I just don't know how to solve them, right? To be
Absolutely. No,
completely transparent.
Right.
But this is the part that's very important. Every year, and we're going to get this validated when I talk to Debbie Adams. Every year, only about 150 perfusionists graduate into the workforce every year. So that's somewhat redundant. I'm not sure exactly who wrote this, but they really need to work on their editing skills.
I agree.
I did not say that incorrectly. I'm reading it, okay? And it's estimated that only 320 perfusion positions are open around the country. Now, those statements are contradictory, if you can tell, right?
Correct.
In tone. So they're saying that only about 150, but then only 320 positions are open. So I'm not sure if that really, so only 150, but only 320 positions. I'm not sure what they're trying to say there. It would have made more sense if they said that there's only 150 perfusionists that graduate into the workforce every year with an estimated three. If they took out the word only does not belong there.
Right.
Unless, because I don't know what they're trying to convey.
Yeah.
But roughly 44% of the active perfusion workforce is over the age of 50, and with more than 300 leaving the profession every year. Now, I'm over 68 and a half now. I
Right.
am on the backside of 68.
Correct.
And I'm going to tell you what, this has been one fast year. Every year gets faster.
Right.
Which is really disturbing me.
Yeah.
Okay. Because I ain't got that many of them left.
I mean,
right?
we're exactly halfway done.
Yeah.
I mean, as of today,
You
when
are.
today ends.
You are?
No, for the year.
No,
is what
for
I'm
the
using.
year. I
Yeah,
know.
Yeah.
I
Where
know.
did it go?
I know. Thanks, Samir. Thank you.
Just-
I appreciate
yeah.
that. But anyway, that's the numbers that they say. And I think this is really important. But specialty care is working to fill these gaps by leading the industry in perfusion services, providing jobs and training for perfusionists. And really, of course, if you want this to be a profession, then they should not be providing training for perfusionists.
Right.
Because one, it's a conflict.
Yeah.
Number one.
Absolutely.
And number two, you're implying that it's an OJT program by saying that, because you have to you don't meet the qualifications of KHEP.
Right.
So that means you're either sponsoring a school or you're putting people through school, but it says they're training
I heard they are opening a school, aren't they?
training for perfusionists. I don't think they actually are in there. I think it's both the Lipscomb College one and the Thomas Jefferson
So
one.
sponsorship.
I think there's some kind of joint affiliate. I don't know the exact structure, but there is some involvement.
Okay.
But I don't know to what level that it is or isn't.
Right.
And then they talk about their team and so forth and so on. So I'm not going to get into that. But let's just do this if we can, and let's take a tour around and see what there is.
Yeah.
Top healthcare careers. So it's going to start with just healthcare. Salary and career growth. And I looked at this, and actually I found it to be fairly close. It was kind of interesting.
Okay.
And this is nationally. This is not looking at this and any one given geographical area, if you will. But average salary for a registered nurse, $77,600. Now that includes all, so that's ones that work in jury care and ones that work at the
ICUs,
VA
yeah.
and ones that work at the ICU,
Right.
critical CVICU, cath lab, all of these things, emergency room, all of that stuff. But basically, we know what their skills are. I mean, everybody knows med. I'm not going to go into that. But minimum bachelor's degree required, which is not correct. That is actually incorrect. You can have a degreed program, or not a degreed program, a associate degree, associate's program of nursing. That is correct. And still be a registered nurse. But I do think that to get into the CVICU or the ICU, you're really looking at needing to have a bachelor's. I don't think there's very many graduate certificated or associate programs where you get into the nurses that get into there. Career outlook, they're considering a 6% growth from 2021 to 2031. Average salary for a dentist, $163,000. So the next time you are in agony and you need your tooth drilled or a tooth pulled or whatever, and it's in the middle of the night, please take into consideration that dentists, not oral surgeons, but dentists, do not necessarily make a whole lot of money unless they run the practice. They own the practice, right?
Right.
That might be a little bit different thing. But of course, you need a doctoral degree to be a dentist, right?
Right.
So different thing. And, your work hours are, I'm sure, variable, but you go to an office and you're there, you're going to be there all day.
Yeah, absolutely.
Okay, it's going to be all day. It's probably going to be 10 hours a day, 4 days a week, or it's going to be 8 hours to 10 hours a day, 5 days a week.
Yep.
Generally speaking, though, you're not on call, and you might have a practice that works like that, but most don't. You can't find a dentist in the middle of the night. You cannot find a dentist on the weekend or a holiday.
You sure cannot.
So they do have that advantage. Nurse practitioners, average salary about $120,000. Again, this is all comers, and this is going to be for people for everyone who works at the Minute Clinic, urgent cares, to the nurse practitioner. So this is median, right? Average salary, okay? And so you have to take that into consideration. Nurse practitioner working in in a high volume, high intensity, tertiary or especially quaternary facility is going to in CV is going to make a lot more.
Yeah, make
right?
a lot more. Yeah.
Maybe, right? I don't know.
Yeah,
but
that's true.
Look at the anticipated growth, 46%.
Wow.
46%.
Wow.
Because they're trying to do away with general practitioners.
Correct. Yeah, you're right.
They want one general practitioner essentially supervising 10 nurse practitioners or something of that sort. So that's what you're going to start seeing more of. I think that is a pathway that's something we're going to see. We're going to see the general practitioner
Dwindle down in
really
their numbers.
dwindle down.
Yeah.
Physical therapy and even hospitalists, you're going to see the same thing.
Right.
Physical therapists, they make about 95,000. I think that's about right. I know a lot of people that are physical therapists, and they make about that much. Physicians, now again, this isn't heart surgeons, and this isn't, interventional cardiology, but it's all physicians. That includes hospitalists, right? ER docs, could be internist, could be neurology. You add them all up, look at the average, 208,000. For as much education as they have to have just to get through medical school.
Yeah.
If that's the average salary.
That's terrible.
Some of them are really, and they're working hard.
They work hard.
I'm going to tell you right now.
I used to work very hard. Oh my God.
I'm going to tell you right now, it is really it's a tough life being a physician.
It is.
And it's so incredibly political, and it's so incredibly cutthroat. And man, I'll tell you what.
Nowadays, they work even when they get home, Joe. They take their notes and all that with them home. They'll write their notes at home because they don't even have time to write their notes when they're in the hospital. Oftentimes,
right.
Especially like intensivists and things like that.
Yeah.
They don't have time like that.
Right. And everything they do is now RVU driven, right?
Exactly.
It's very funny to me that when you look back at the history of medicine, hospitals were built by physicians, and they were run by physicians.
Right.
And then somewhere along the way, they decided, you know what, we need to hire these administrators to help manage the finances. We can't do that and run this and do all the the procedures or taking care of the patients the way we're doing. So they hired them, and now they work for the administrators.
Right. Exactly.
Yeah.
And
the growth in administrators is a very upward trajectory, and the growth of physicians is actually a decrease.
Right.
So you see way more administrators being hired than you see physicians being hired.
Yeah, because
there's a shortage of good physicians.
Oh, absolutely.
Especially cardiovascular.
Yeah,
especially.
I agree with that.
I think we're at a
100%.
critical mass, I think, at this point in time. And then pharmacists make about 128,000. With that bad life for sitting there, I guess, filling prescriptions all day.
They have one of the best lives, I feel.
Yeah,
I mean, you
pretty
sit
good. Well, I don't
around.
know. Do you ever see some of these people at CVS and Walgreens?
Oh, I wouldn't want to. Yeah,
they don't look too happy.
They don't ever look happy.
They don't look too happy. I've talked to several of them. I actually know several of them.
I know
as well.
a couple too.
And they
that actually work at CVS too.
Yeah. Now you could have a job as a nursing assistant, which is the person who's going to be cleaning up all the poo and all the vomit and all the excrement and doing all all of the literally, I guess I could say it, all the shit work.
Right.
Okay.
That's
They're making
literally
about 30,000.
it's
Now
terrible
they
how
don't
that
have
works
much
out.
of an education requirement. They need to have a high school, and then they go to either a technical school or community college. But you know what? They do a lot of hard work. Oh, let's go back to this. Pharmacists are growing at 2%. Dentists are growing at 9%. Nursing assistants are growing at 5%. This is going to be from 2021 to 2031. So now surgeons, same as physicians, only they have additional training. I think this is probably more in the podiatric space as opposed to in the certainly not in the CV space.
Definitely not the CV.
No, I would say their minimum
I wouldn't even
starting
want to
is
go to a CV surgeon that only makes 208,000.
No.
I will not let that guy operate.
No,
on
they're
me.
they're probably starting them out at 350 to 4.
Yeah,
I'll bet.
Yeah, they are.
350 to 4.
I would
350
say
to 4.
my brother-in-law's starting was about somewhere about there.
Yeah, and that's dude, for doing CV, CT,
And then they progress higher quick too.
you do.
Yeah.
But again, it's RVU driven.
Exactly.
You
It's
gotta
all-
have the you gotta have the billable service. If you're not
you
bringing
do.
the billable services into
It
the
doesn't-
hospital,
right.
you're gonna get your base salary.
Yep.
But that's all you're gonna get. And if you don't
That's
ever get
exactly
much
it.
above that, they're gonna find somebody else to do it.
Exactly.
Radiology technicians, 61,000. And look, let's see what the growth is on the 3%. They say for surgeons. Well, that's all surgeons. All surgeons.
Okay, yeah.
CT, yeah.
Which makes sense.
Medical clinical lab techs make about 58. Phlebotomists make about 37. Respiratory therapists taking care of all of the mucus coming out of your airway, 62,000. Probably make more if you're in the ICU, but
Yeah,
not
absolutely.
really a lot. And you wonder why it's so easy to find these
No.
people that they want to be ECMO specialists. They want to be
Exactly.
ECMO specialists.
And perfusionists too.
Right.
They're
Well, they go to
huge.
perfusion school.
Yeah, that's
but,
huge.
But it's really good for them. ECMO specialists, a lot easier training for them
absolutely.
to do.
Oh,
The-
yeah,
the
much easier.
The problem is that I don't know how they. I don't know, man. I don't know how they. I don't know. It's interesting.
Mm-hmm.
You know, I'm not sure. I don't know. Do you have a feeling about that? I've got strong feelings about that. You know, in terms of who should be an ECMO specialist.
Oh, I remember you actually
Yeah.
brought those feelings up, but that you don't agree with it.
What do you think? What's your opinion?
Honestly,
Well, I would
I
hope every
feel-
time. I hope you're
well,
only honest.
Okay, so I'm actually okay with it in the scope that it depends on who is. So they have some pretty stringent requirements. They don't just let anybody come. They usually require you to be some kind of medical professional, whether it's an ICU nurse or a respiratory therapist. So you do have some background knowledge to build upon. I would not be okay with. I'd be okay if you're at a certain level of education. Let me say that.
Now, I'm talking about the differences between respiratory therapists and nurses being ECMO specialists.
Oh no, I would rather have I would rather have a respiratory therapist be one.
As an ECMO specialist versus a nurse?
It depends on the nurse, Joe. Were we talking a CVICU
Yes,
nurse?
CVIC.
Oh, then that,
So
for
the
sure,
requirement.
yeah.
Okay, so let's be clear.
Okay.
The requirement to be an ECMO specialist
Mm-hmm.
for us,
Right.
maybe not everybody, but for us,
Mm-hmm.
is you have to be a CVICU nurse with a minimum of 3 years experience, and you have to have, and I can't remember the exact number of hours, but a fairly significant number of hours managing patients on ECMO. Not that you were doing anything with the ECMO, there was somebody else
But
there.
your
were
patient
taking
was on
care-
ECMO.
Your patient was on ECMO.
ECMO.
And then you have to take our course.
Yeah,
and then you have to pass the ELSO exam for the adult
Sure.
ECMO certification from ELSO, and then you can work for us.
Oh yeah, absolutely. Then
So-
definitely that over an RT for sure.
But respiratory therapy is also legitimately able to take that same course and take the ELSO exam.
do you have do we allow RTs?
No.
No.
But that's what I was asking you.
So
is
CVICU
what is your view on
nurses,
that? I have
especially-
my feelings about it. What's your feelings about
I
it?
100% agree with the CVICU nurse. I would rather train it. If we were to ask who would I let put me on ECMO, CVICU nurse, especially with ones with experience with ECMO. Like you said, they may not touch the ECMO, they may not change the flow on the ECMO, but they've seen it enough that I'm sure they know what to do without you actually doing it.
And I just don't think that that respiratory, they come in, they do the vent thing.
They're
but
not
they
there the
really-
whole time.
No, they're in and
Yeah,
out.
yeah, they're in
right?
and out,
They don't
yeah.
have the same, and they don't
No.
understand, my view, the patient milieu.
Yeah.
They don't understand the renal component
They
of
don't
it.
under-
They
they don't have the whole
understand
picture.
The
They-
nutritional aspect of it.
It's-
Does does the patient have bowel sounds? They never
Right.
think about that.
RTs
know,
only know, like you said, mucus
Bleeding,
and
coagulopathies,
Right.
all of these things.
Yeah, no.
They're very good with heart and lung and ventilators. I'm not
Right.
going to dispute that, and I
No,
think
yeah.
they're very intelligent people. I just don't think they have the experience taking care of the patient as a
Absolutely.
global
Yeah.
organ, globally.
Yeah.
The entire organism. Anyway, moving on from, they're looking at 14% job growth. Medical assistants make about 37,000. Sonographers make about 75. That's actually pretty decent for
God.
doing.
I didn't know they made that much.
Sonography.
That's so
and
weird.
yeah, and
Some of these salaries are just weird. Like, how do these guys make that much? But then
it's supply demand.
Yeah,
right.
I
It's
guess
supply
so.
demand.
Yeah,
And I'm
that's
going to tell
exactly
you,
what it is.
you ever watch some of these guys that do these transthoracic echoes? I tell you what, man, there's a lot of skill to it.
oh, absolutely.
There really
yeah,
is. I can't find it. I can't find some of the windows they find.
No,
My
yeah.
daughter does this, as a matter of
Yeah.
fact. She's an echo tech, I guess you call them. And but she did sonography and vascular, and then she also did the echo portion of it as a separate program.
Right.
No, I mean she can read a damn echo better than I can.
Yeah, that's
A transthoracic echo.
sure. And those are the hard ones to do. I
They
mean,
are.
Yeah, they're very hard
Everything's
to do.
backwards. It
Yep.
doesn't. I mean, the TEE is much more intuitive.
Yeah, much more intuitive.
Makes sense. You know,
makes
you're
so much more
yeah.
sense, and so
The
much easier
ventricles
to
are
do.
actually on the bottom, like they're supposed to
Exactly,
be.
yeah, not
as
upside
opposed to on
down.
the top.
Yeah, right.
Upside
No, no,
down
no.
and inverted, and
Yep.
it's like, what's what?
Well, exactly.
Yeah, where am I looking? Yeah, but you only need an associate's degree and sometimes specialized training. EMTs make about 37,000.
That's tragic. I feel
That's
they
a horrible
should-
job.
that's a
Dental
horrible
assistants
job.
make 38,000.
What in the
Genetic
world is a
counselor
genetic
makes
counselor?
80,000. I don't know, but I remember going to one once and they said my genes were bad. Occupational
genes.
therapist, OTs make about 86.
Okay.
Optometrists make about 124. That's not a bad gig. Audiologists make about 78. I guess eyes and ears are less valuable. Speech pathologists make about 76, and that's a PhD program. To be a speech pathologist, no, actually master's degree. I'm
yeah, it
sorry,
says, yeah.
a master's, still a master's degree.
Yeah, that's
right.
still-
A master's
yeah.
degree making 76,000. You think about that.
Yeah, that's horrible.
You know, that's
Yep.
totally different. Pediatricians make about 170. That's not enough for all them screaming kids. Anesthesiologists 208. It's like every other physician's
Right.
salary that we've seen.
I think they lump
it's
them
all
all
about the same.
together. Yeah,
right?
they're
But
all
they're
just
making
lumped
more
together.
than that. I mean,
Especially
average
a CV
chiropractor
anesthesiologist.
75,000. They shouldn't make anything. And that's it for that. So I thought that was interesting, at least to look at other healthcare fields. So let me come over here.
I love how we're
And-
never in any of these.
I'm sorry.
I love how we're never in any of these.
No, we are
You won't
not.
ever find perfusion in a nothing.
No, we will not. We
We're like
will not.
secret. Nobody knows what we do.
Where
Nobody knows where we
is-
are.
There it is. Here. And so let's look here. Oh, that's
That's the same thing. I
the
think.
same thing. Yeah. Let me go back. Sorry. And do this one here. Ah, this is a
Yeah.
good one. Yeah. So let me open this other one first.
This one looks fun.
That's okay. You leave it up, David. This narrows it down a little bit more. There we go. So here we're looking at hourly rates, median. So their range is 27 to 47. So that's going to be somewhere around
You just multiply it by
70,
yeah.
70,000 to about 100 and probably 120,000. What is
Yeah.
that? What's 47 times
Well, on a
28?
40-hour week, you just multiply it by 2-ish.
Yeah.
So it'd
40
be 50 to 90, 95 to 100.
So
about 60 to 100?
47.8 times 2080 equals 99,000.
Yeah, so about 100-ish.
Right, about 100.
A little
And
bit
then
more
you-
than times 2.
yeah.
So
and
47 times, a little bit more than times 2. It's about 100-ish.
Sure, and there's some differential. Yeah, exactly.
Yeah.
There's some differentials and stuff like that. Software engineers are making somewhere between 70,000 and 135,000, so that's not too bad.
I don't envy their job. But trust me, my wife's one. It's rough.
Yeah, me
they
either.
work all day, dude.
I could just imagine.
Yeah. I mean, she's lucky she gets to work from home, but man, she is on that laptop all day.
Yeah, I couldn't do that.
It's-
HR managers make about 56 to 102. Project managers, unspecified type general, they're making somewhere around 121, 122,000 a year. LPNs, 19 to 30 an hour. Mechanical engineers, 63 to 111. Let's see, director of operations is making somewhere between 61,000. That's quite a spread, and 169.
That
No,
is
that's
quite-
hourly rate.
Oh, yeah,
I'm
okay.
sorry. They're making, well, that doesn't look
No,
like an
that's
hourly. That
definitely
looks
not-
like a
that's
yearly,
definitely
right?
not an hourly
Yeah,
rate.
that to 169,000. Yeah, that'd be great. I'd like that job. I would love
I'm in the
that
wrong
job.
field, Joe. I'm
Yeah,
in the wrong
exactly.
field.
Me too. So
I'll
I'm
even
gonna-
take the lower end of that
Yeah,
median. I'll be
so-
good with 61,000 hourly rate.
So we could go through all of this. I think it's probably worth it. Let's look at education. Let's see what teachers make. Let's see if that let's see how about a not special ed? Let's see if we can find. Let's find somebody. Well, what does an athletic director make? That seems like a job that interesting. 71,000 a year
Gosh.
for an athletic director. Okay, let's look at a child care teacher, instructional. What's that? A paraprofessional? I don't. Oh, that's probably somebody who's paraplegic or something like that. Financial aid director.
Okay.
73,000. I'll bet this is going to be pretty consistent in the education space.
What about like a college
Physics
professor?
education director? That's a tough one. 54,000 a year
That would be.
for a physical. Oh, that's physical ed.
That's a,
physical ed
That's
teacher.
a-
I'm sorry.
That's a gym coach.
Not physics. I'm sorry.
Yeah.
Yeah, gym coach.
Yeah.
That's overpaid.
It really is. God.
English as a second language teacher, 54,000 a year. So that's that on that space. Let's pick a space. Pick something.
Let's do. Let me see what we got here. Legal. Let's see what lawyers. are doing.
Legal?
Yeah.
Legal. That's under L. HIJKL. Legal.
Up there, top
Yeah,
left.
I found it.
Yep.
I found it. So we want attorney
Right
lawyer.
there. Perfect. Right there. Yeah.
Attorney
See-
lawyer.
Yep. Let's see what they're doing.
$102,000 a year. Now, I know a person who is a professor at a fairly well-known
Law school.
and she earns her base salary is $65,000 a year. She's an attorney.
That's terrible.
That's her attorney. That's what she makes for teaching at a law school.
It's terrible.
Fairly well, not, it's not, it's
Terrible
it's not
considering
Harvard.
That's
right?
a little bit less than.
But-
that's a little bit more than the gym coach.
Yeah.
Like-
But what she has to do is she has to do private practice work
To keep making
on the
ends meet.
side, and she makes more money doing that.
Oh, yeah,
but
absolutely.
she really enjoys this, and so that's the conflict that she has.
That's
And
how-
she knows she's taught for so long
Mm-hmm.
that she goes to court on these other cases,
Mm-hmm.
and most of her opposing counsel and even the judges are people that she taught.
Yeah, this country. That's the biggest problem with it. Is that while we value teachers so highly, we just don't pay them enough.
Yeah.
In India, that's not the case.
Yeah.
India, they're highly regarded first and foremost. A teacher's like doctor level respected position, and they're paid quite well.
Yeah. Now, you would agree a law clerk is a big time position, right?
Absolutely, yeah.
Let's see what a law clerk makes.
What do they make? That's gonna be-
$19.92 an hour.
Gosh.
Okay. Let's look. That's a law clerk. Okay.
Yeah.
A litigation attorney, $122,000 a year. Now, there's always those that make more, right?
Absolutely, yeah. This is
There's
just
more
the
than one.
median.
There's
Yeah.
those that make more.
Yeah.
Managing partner in a law firm,
Oh, okay. This one.
200,000 or more, right? Probably between 200 and 400,000. I think that probably makes sense.
Yeah, definitely. And it depends, obviously,
Yeah.
on the law firm, right?
Yeah, I think so.
Yeah.
Attorney lawyer at a law firm, 117,000 makes sense. Probably about it's about right.
Yeah, that's about
you
right,
know,
yeah.
you go in and you work at a law firm, and if you're on
Yeah.
if you're on the on a partnership track, you're taking it in the shorts, dude. You're working your
Yes,
ass off for
you
literally nothing.
Yeah.
So
And
okay.
that's how what they do until they get that partnership offered to them, and then
I
they get
agree.
to buy in, right? Like,
How about we look at the
and then they have to buy in too.
Here's a good one. I like this one. How about we look at the assistant attorney
AG.
general? That should be a good one.
That should be a good one.
Less than 100,000 a year.
Yeah, because that's a government position, so
Less than
never gonna be that
100,000 a
high.
year. Attorney general.
yeah.
How about deputy? Oh, that's deputy general counsel. We don't
No,
do
yeah.
that. No, I think we've beaten this up enough. I think that's
Yeah.
given us. And to be a lawyer, you got to go to law school. You're a doctorate.
Yeah, and
You
it's
are
expensive.
a jurist doctor,
And
right?
It's expensive, right? Exactly.
Very
It is a
expensive.
doctorate, yeah.
Very expensive. Not easy at all to do. Okay, we'll do
No.
one more. Pick another one.
Let's do the next most common thing, which would be retail or sales, whatever one you feel like doing.
Yeah, let's do
Science biotech.
Yeah, let's
that's
do
a good one.
Or
yeah.
protective services.
Yeah, I didn't see that
Either
one.
this one's going to be cops and this one's going to be science and bio. Maybe there's astronauts in it. I don't know.
Let's check it out.
Let's see what a
Click on it.
chemist makes. 66,000 a year. And
Gosh.
I'm assuming they're going to have to have a doctorate. I don't know how they could not have to have a doctorate. Maybe at least a master's. Principal scientist. 131,000 a year.
Wow.
So
That one you
postdoctoral
definitely
research
need to-
associate, 60,000 a year. They're working for free,
What about a
doing
psychologist?
all of the work. We're psychologists.
It's right there in the middle of
the
the
middle?
page. Right in the middle of the page.
Go up or down.
Down.
Clinical
Couple more down.
psychologist. Oh,
Yeah. That, and then there's the
clinical
regular.
psychologist
Always
is that,
wondered how
and a
much they make.
psychologist.
Those are like
91.
regular therapists, not
Yeah.
not the
Right.
talk therapists.
Right. They're not.
They won't prescribe
They're not
medicine.
psychiatrists.
They're not psychiatrists, right? Who can prescribe the
These are
medicine?
like family counselor type
Exactly.
people,
Yeah,
things
yeah.
like that,
Yeah.
or whatever. Yeah, yeah. I don't think it's not enough money for me to listen to your problems. I got my own.
Exactly.
Okay, and since we're there, let's see what cops make.
Yeah. Let's see.
Police or sheriff's patrol officer.
That's another usually
62,000 a year. There's a
see?
theme here. You see, these
Yeah.
ranges are actually
Yeah.
really pretty close.
That's
It makes
another
it-
one that's very highly paid in India, but not so highly paid here.
Right. How
Cops
about
are very again.
how about
very
a
respected.
correctional officer?
Oh, God,
21, 23 an hour. Woo!
I would not want to do
And
that
a corrections
job.
officer should be 20, so a little bit higher
Mm-hmm.
by a couple of dollars. A fire chief, 88,000.
God.
Mm-hmm.
You would think it would be higher.
A fireman or woman, 50,000. That's about right.
That is about right, but
It is about right. I'm telling
they
you.
live a good time. They always like I've spent some
I wanna
time in
see
a
what a
firehouse.
store-
They look like they're usually
Store
having fun.
detective, 14, 15 an hour. So I'll tell you, when you complain about the justice, let's talk about our job because we're going to run out of time. So
Yeah.
real quickly, because I want to make sure we get all of this covered. Perfusion is coming out of school 140, 145, probably just if they're just graduating. Depend on your market, right?
Correct.
If you're in New York, obviously it's going to be more. I mean,
Obviously.
come on.
Yeah.
You're in Los Angeles,
Yeah.
whatever, just taxes alone are going to kill you.
Yeah.
So the amount you're going to make is going to be more. But on average,
Correct.
it's going to be around that.
Yeah.
Okay. And then if you're around for 12, 15, and probably 15 to 20 years, you're going to be making somewhere between 180 to 200 in that range. Probably pretty reasonable.
Right.
About what you're going to make.
Yeah.
Unless again you're in one of these remote areas where
Right,
you're on
where you're
call
gonna
all
get-
the
yeah,
time,
and you'll get
and
paid a
there's
lot more.
exceptions to all of this,
Right.
but that's probably fairly close.
Travelers make a lot.
But what we didn't discuss, travelers make more, but is that going to come to an end? We're going to
Yeah.
find out here in the next session,
Yeah,
okay? When
yeah.
we call Deb Adams and we
Yeah.
find out about that. But when you consider what the workload is like for these people, the police officers, the teachers, all of these people, they are at work 40 hours a week.
That's true.
They go to work Monday through Friday and sometimes even more.
Right.
They may be paid a little extra, a little overtime or something like that, but the amount they make, the overtime isn't really that much. Maybe it is to them, and I'm sure it is. But I don't know what additional benefits they might have.
Right.
But I can tell you, the deputy attorney general is probably working way more than 40 hours a week.
Way more.
Physicians are working way more than 40
more,
hours a week.
Way more. Way more.
Very, very rare.
Oh God,
to
40
see-
hours like a slow week for a physician.
Right. Just
Yeah.
work 40 hours.
Yeah.
Dentists are working
Yeah.
way more than, and they're going patient to patient to patient to
Yep.
patient to patient to patient to patient to
Yeah,
patient.
with no breaks.
They have multiple patients going on at the same time, and they come in and they try to be in a good mood and do their thing. Radiologists are sitting at that screen day after day after day in the dark room looking at that screen when AI could do it better. But, of course, I think you still have to have both. I would not trust only a computer, but I would love for the AI to be a adjunct to that. And we're going to do a lecture coming up, by the way. There's a fellow that I met. He's from, I believe, Belgium. And he's here in the United States. He was a perfusionist there, couldn't be a perfusionist here. I even asked him, I said, you want to be? Because I have a pathway that we could maybe get you into. He said, no, not anymore. I'm done. I don't want to do it. I think his wife, I remember what his wife does, but he did an excellent lecture at Texas Heart program this past, like a month ago. And it was on AI and perfusion. It was very, very good. He's going to give a lecture for us at our new studio, great. But he'll come in remotely. But the guy is really phenomenal, just a super good guy, very, very, really intelligent. But perfusion has a very strange lifestyle. We don't have, unless you work at a very big institution, your hours are very variable. You could be out by noon with no balloon, starting a heart at 8. You could be there starting a case at 9 o'clock at night for a surgeon that likes to do elective cases in the middle of the night. You could be getting called for weekend cases, but you could also not be being called at all. It's very variable. It's very rare for a non-institutionalized perfusionist, in my opinion, to be at the hospital 40 hours a week.
Oh, no,
Extremely rare.
Yeah, very rare.
But if you're institutionalized, then you are.
Yeah, they have shifts.
At least.
Yeah.
Right. Yeah. It's a totally different thing.
It's a totally different
And that's something that I think perfusion does offer, is that you have a lot of variability in that.
Right.
But given what our educational requirements are, which at this point is still a bachelor's, they're moving it to master's.
Right.
But bachelor's degree with certain prerequisites. And the amount of time it takes, you could get through it a year. You could, 18 months.
Yeah.
Even if it's 24 months.
I got through it a year.
In a year? It's pretty good. When you compare it to these other industries and disciplines, we're doing pretty damn good.
Absolutely.
But where's the upper limit on it? And should we be satisfied? Should we be pushing for more? Because that's a supply-demand issue.
Yeah.
Right? And salaries exploded over the past 5 years.
Absolutely.
Just exploded.
Yeah, you're right. I mean, I've seen what it was 5 years ago.
Yes.
It wasn't like what it is now.
Not even close.
After COVID, things just took a turn for perfusion.
Well, there was a shortage before going into COVID. COVID only made the shortage so incredibly obvious.
Right.
But we were already in some level of shortage.
Right.
Prior to COVID, and COVID just absolutely created so much havoc. We could do a whole weeks of programs just on that one thing.
Right.
Everything about COVID. Right. We could talk about indefinitely. But I don't know. I mean, are we our own worst enemies? Are we peeing in our own cornflakes, so to speak? Should we be a little more satisfied? Should we want to do a little bit more? Should we push the envelope more? Should we expect more, or should we be like really happy and maybe give back a little more? I don't know the answers to that.
I think it's a combination of all of that you said. Should we stop pushing the envelope? Absolutely not. You have to push the envelope. Otherwise, we'll stall out, right? Like, you don't want to do that.
Yeah.
Should we be happy? Absolutely. I mean, you just said it. We have a pretty good gig, but does that mean that we get complacent and just sit still? No, you never do that.
But what makes people go to the other side? What makes them think that the grass is greener on the other side of the hill?
Human nature. Everybody thinks that always. I mean, it's easy to focus on negatives and think that somebody else has it better. I mean, people, like you said, at the beginning, you were like, when we first started talking about this about physicians, everybody thinks they want to be a physician. Trust me, I've been there, done that. It's a hard life. And, you don't, all my myself included, and every physician that I have ever known, at some point in time has questioned why the hell they became a physician.
Yes.
Myself included.
Yes.
Okay? Like, why the hell did I choose this field? Because it is an incredible amount of work. And if you, yes, the pay is a lot, but if you break it out to pay per hour, it's not that much.
No,
there
you're
are
right.
plenty of other professions that make a lot more per hour.
Yes.
And I would go as far as saying I think Perfusion might be one of them.
Yeah.
Per hour. Like
Yeah.
you said, we don't hit 40. These guys can hit 60 easy. You know?
And still have call.
And still have call. And still go home and have to write notes. And this and that.
Yeah.
They can have 60 hours hospital time, and that doesn't even include all the other nonsense,
Yeah.
like you said.
You could be
call
an astronaut and go up to the space station for 2 weeks and be there for
Yeah.
2 years
So
because they can't get you back.
exactly. And then I mean, so
And you're still just getting paid the same.
So I
you don't get overtime
no
for being there.
No, you don't. And
You're
that's
salaried.
the worst. And that's the worst part about it. And you know, yes, the respect is there. Yes, you know, it's nice to walk around the hospital like your shit don't stink. You know, that's nice.
And people respect you when they meet you.
Absolutely.
Oh, you're a
And people
doctor.
do respect
You're a
you
doc-
when you
yes,
meet
it's
you.
still considered
Correct.
an admirable profession in this country.
Absolutely. But, you know, even as a doctor, I spent time, you know, noticing that the grass is greener on the other side, kind of like you said earlier. I mean, it's just the way we are as a people, you know.
As a
I
species.
try and, as a species, yeah, absolutely, as a species and that is what makes us push the envelope.
I guess only people are our species, but
Well, Joe, yeah. We got the Cro-Magnon men. They're technically
Yeah.
a different species. Like,
that would be me.
yeah.
Okay. Okay. With all of that said, we're gonna go on into the next thing, and the next thing we're gonna talk about is I didn't mean to do that.
What did you
I
do?
just really messed up, dude. Hold on, YouTube,
Lord, how did
Yeah,
you
I
get to
know.
the Idaho stuff?
dude. I don't know.
Crazy
I'm
snipers, man.
falling apart, bro.
Snipers, man.
I'm falling apart. YouTube Studio, is that right? Is that how I did this? And then go to video. And how do I get to the video? I forgot. Content. Thank you.
Ah.
And then live. I'm just trying to pull it back up again.
Pull up the current.
Thank you.
There we
Okay.
are.
I don't know if anybody made any comments.
Oh, yeah.
In my center, the CVI nurses seem to have a better understanding of full body medicine in comparison to the RT ECMO specialists.
Absolutely.
The exceptional RT specialists go way beyond to close the knowledge gaps. I completely,
Absolutely.
Liam, I appreciate that comment so very much. And I agree with you 100%. There are exceptional
Yeah.
RTs and there are not so exceptional nurses. Agreed. But as a whole, just their level of education and experience, I agree
Absolutely.
with you 100%. And Michael Brenner says, having trouble logging into your website,
It's
still
Michelle
able to
Brenner.
get credit from watching on YouTube. Yes, sir.
Michelle.
Michelle. I'm sorry, Michelle. Sorry, my eyes. Michelle, yes, absolutely. So I'll make this clear to everybody. Everyone will get credit if you're signed up for any of these programs, especially since everything that happened. You know, I'm taking it on faith, and I think that it's reasonable for me to do that. That anyone that was going to be here is here. You know, I don't usually have these issues, so I believe the board will show me deference. I would be the one in trouble, not you. But if you can just send me, like you just did, a little note, an email that yes, I attended, something that I have, so I have a record of that on file, it'd be very helpful. But yes, it doesn't matter if you didn't pay for it. If you did pay for it, you know, and I'm going to refund anybody that got grossly inconvenienced. And if you aren't paying for this today, you're not going to have to pay for it. You're just getting the certificate for free. I have to do something to make up for what was my failing. So I appreciate that, Michelle. Good question. Okay, and then so next on our list is the perfusion crisis, the staffing crisis over? That right? Is that what we're supposed to do
I thought
next?
we were going to do the inept one.
No, we're doing the.
Was the how to report an inept surgery?
Oh, that's right.
Yeah,
we're
'cause
doing
gonna
that
do
right.
the staffing crisis last, so you can
Correct.
call.
Thank you. You are correct.
Yeah.
So I'm going to let you take the lead on this one. Okay, you're both a physician and a perfusionist. you didn't only graduate from medical school, because there's a lot of guys out there. Look, I'm going to tell you something right now. There's a lot of guys I know who went to medical school and wherever they went, Timbuktu, Caribbean, Jamaica, Grenada, wherever. Some obscure college somewhere, got their medical degree. So they technically are MDs.
Correct.
But they never practiced medicine, ever.
Right.
And so, I find that, I find that unappealing for me. It's not attractive to me, especially when they put MD on their jacket and they act all huffy and big, high and mighty. It doesn't impress me much, but you actually did not only go to medical school but practice medicine for several years, 6 years, in a very intense tertiary care hospital, and did you do transplants there?
No, they didn't.
So it's tertiary care.
No, it was tertiary.
But in a stroke clinic, and I know you to have not just the fundamental knowledge of medical school, but you have the experience tying all of that together. So I feel like you have good standing, and in that regard, I have a lot of respect for you because of that. And it's deserved. So in this case, I'm going to let you start it. And I'm going to pull up Dr. Bhatia's number and see if he is able to do this. Yeah, so I'll let you do that.
All right. So, what do we do when we come across inept surgeons, inept physicians? First things first, I guess, let me try to, let's talk about the guy that, always comes to mind when you think about this field. It's Dr. Death, right? I can't say his last name. Christopher
Dunch.
Dunch. There you go. So, who was Christopher Dunch? For those of y'all that don't know, he was a neurosurgeon in Texas. This guy was horrible, okay? I mean, he operated on 38 patients. 33 of those patients were injured, maimed, or dead. Combination of all those 33 of those patients. Despite all this, he kept, getting new jobs, kept getting hired on by other places where he would continue to do the same thing, because no one ever said anything loud enough. Nobody ever said anything early enough. They just kind of carried on, the way that they did what they did. So I guess the question is, what would you do, if you were in that room? Would you speak up? Would you stay silent, Would you try to fix it on the back end, So basically, it's a question of, not only professionalism, but ethics and effectivity, like how effective is the person that is performing whatever procedure, or again, this is not just about surgeons. We're also talking about the staff in the OR. It can be anybody. It could be the perfusionist. It could be the anesthesiologist, it could be the nurses, it doesn't matter. It could be the surge tech, anybody.
But I'm going to say this, when it's the nurses, they'll cut them off, they'll cut them
quick.
Quick.
It's because there's so many of them to quality grade each other in that room.
I think they're held to a different standard.
I agree. And
I think it's a problem. And I'm going to preface this all with something that and I love your beginning of your intro to this, and I'm just going to throw it in there with you if you don't mind.
Yeah.
And that is that there is a perception in the global community, and there's definitely a perception within the healthcare community that doctors protect each other.
Oh yeah.
That is a perception.
Yeah.
And and I don't really think that's true.
Because doctors testify against doctors in court.
Yes. I don't really think that's true. I think what it is that they don't want to be labeled, okay, because, you did this to some other doctor, especially if that person, whether they were good or not, had friends that are also doctors in that same facility.
Correct.
And so you get a mark on you. You become known, for that.
Yeah.
Number one. And number two, the fear of being sued.
Yep.
We live in, that's the second issue.
That's always
just a huge, and it shouldn't have that.
No.
You should not have that.
No.
But I can tell you, I have seen some totally incompetent surgeons be permitted to go on and on and on. And I'm very much looking forward. I hope Dr. Bhatti will answer. I sent him a text because I think he's going to have a lot to contribute because of his position within the Texas Medical Board.
Correct. Yeah.
But go ahead. I'm so sorry.
No,
Forgive me.
you're okay.
I'll let you continue.
No. So I guess, the very first thing is, what is ineptitude? So, let's be clear about definitions. We're not here like on a witch hunt or anything like that. Anybody can have a bad day, but ineptitude, it implies persistent, unaddressed, and dangerous lack of skill or judgment. Okay, that is the actual definition, of what lawyers use when they use this against doctors or anybody, So again, in that definition, the key part about it is the very first part, persistent. Okay, it's not just a one-time thing, even though they can sue you for one-time things, and it's sad, but it can. But we're talking about ineptitude. We're not talking about lawsuits, like you said.
No, we're not talking about lawsuits.
Right, we're not talking about that.
Talking about, right.
So again, persistent, unaddressed, and dangerous lack of skill or judgment. That's kind of what we're talking about here. Again, like some examples would be like repeated like medication errors, a surgeon who continues to like misuse tools or anatomy despite, being corrected, poor communication, or behavior, or anything like that. And communication, people downplay that, but it's a very big problem, especially in the operating room.
Yes.
It can almost always lead to a huge issue. And in perfusion school, they grilled that into us early, how to communicate, closed loop communication, this, that. But then you still make errors, all the time.
Yeah.
It's just a normal thing, But again, so communication, people downplay communication. So we want to make sure we don't, because that is usually the stem of almost most errors that happen in an OR. Again, like inability to maintain sterile technique. I used to know this one surgeon that was really guilty of that. He would really get on you if you broke sterility in any kind of way, but then he would willy-nilly just go around touching anything. He didn't care. This guy grabbed the light. It had the cover on. He still grabbed it by the side and would do it repeatedly, Joe. I was just like, what the hell? Like, is it that? I mean, the cover is on there, dude. Like, can you not just reach up, grab the little green cover, move the light wherever you want it? Do you have to reach around and grab the handle on the side, like, by the light? But again, if one of us did something, all over us, this is in India, so sterile technique is a little bit of the newer thing. They're now really starting to take it seriously. There are hospitals, in the smaller like villages and all that don't care. But even now, with Prime Minister Modi is really big about like trying to bring Western medicine into India and to try to centralize the rules to where even if you're in a small hospital, you still follow, rules. There's like protocols that are written and everybody, does it. It has to do it this way. You're okay to change certain things, but then there's hard rules that are still the same. So yeah, this guy used to just grab, didn't care, but yeah, so even something as simple as that is what I'm getting at. It can be, inept. Now,
Christopher Dunch, he's in prison.
Oh, yeah, he's in prison.
For life.
Yeah, yep. And he got charged for murder, I think, right? Yeah,
for life. Yeah.
He murdered his best friend died. He like operated on his best friend and operated a few times on him or something, apparently. Eventually left him either quadriplegic or paraplegic, but either way, he was paralyzed and then eventually died. Terrible. The whole story. I had to as I was writing it, I was like, I've never read the whole story on the guy. So then I found like an article written on him and actually read the whole story on the guy.
They had a movie on him. They had a television program on him.
God, it's so bad.
Oh, he was terrible.
The fact that he was able to just fly or he was just bouncing around different Dallas hospitals, right? I think. Yeah. And just, God, how people kept hiring him is beyond me, but
And many people, many people complained. Many people complained. And I think this is part of what I wanted to discuss, if I can.
Yeah, absolutely.
And
Jump in.
while we wait for Dr. Bhatia, hopefully he'll catch on. He'll catch up. I just texted him again.
Okay.
I'm going to what is it called when you repeatedly text somebody? What's that called? Text bomb them. I'm gonna text bomb him. Yeah, that's what I'm gonna do, and until he answers me. And he may not be able to. He said he had to check with the board to make sure they were okay with it.
Oh, okay, yeah.
Because he is a member of the Texas Medical
Correct.
Board.
Yes.
So politically, he's going to have to be very careful with what he says.
Correct.
But I'll tell you this story, and I think it's a good kind of story to kind of get into to dissect a little bit. We had I won't say where, I won't say what hospital, I won't say what players involved, but we were doing cases at Hospital X, and there was a surgeon there known as Dr. Y, and he was extremely slow, indecisive, and everyone had a problem. Everybody patient had a big problem, which they would get through, and they would get discharged to LTAC, but they weren't going home. But they were still discharged. When you look at the numbers, because there's all these things that people do to manipulate those numbers.
Correct.
And getting discharged to LTAC is discharged out of the hospital. It's
Right.
not discharged home.
Right.
And it does make a difference, but it
Absolutely.
doesn't ding your numbers.
No, it doesn't.
But it's not good for the
because it's still a
patients.
discharge.
And this person was just, he was venomous. He was toxic. He was just terrible. And people were telling me, we don't want to go. We don't want to go. If I have to go do another one of these cases, I'm quitting. I was like, okay, let me go do the case and see what's going on. So I went and did the case. And I was just appalled. I was appalled at not just the behavior, but at the lack of skill and the it's one thing to be a jerk, but it's another thing to be barely competent, competent, and really almost bordering incompetent would be a more appropriate way to say it. And when it was all said and done, it was over with. I went to the hospital as a business owner
Sure.
with employees.
Right.
And I said, look, this is by experience, and I'm sorry, but we will no longer support his cases. We will not do his cases again.
Correct. Well, you got to
And
protect
they
your employees.
said,
right?
well, you have a contract with us, and you can't do that. You have an exclusive contract with us. And I said, well, that's true. I'll give you an addendum, and we can take the exclusivity out. If you want him operating in your hospital, you're more than welcome to. You can have another perfusion company come in here and do the cases. I'm sure they'll be more than happy to do it. We will not. We're still there, and he isn't.
Yeah.
That was what I did. That's pretty rare.
Yeah. Very rare.
And I had to put my reputation on the line. But it was the right thing.
Right.
I don't think there's a whole lot of people that would take that risk, because that could have affected me very badly.
Well, you could have lost the whole contract.
Lost the contract,
Yeah.
and you don't know who says what to who.
Exactly.
Could have affected the whole company.
Absolutely.
But I had to take that risk. I had to take it. It was the right thing to do. And to some degree, I wonder, should we not just, as clinicians, say, look, okay, I work for you, that's fine, but this isn't worth it. I can't work with this guy. This guy is not competent. Is that how it gets resolved? Because it seems to me that you can report these people. Who do you report them to?
That's
Who
hard
is
part.
what is the process? The hospital knows it.
Yeah. Yeah.
Everybody talks.
Yeah.
So how do they endure?
Right.
What is the process? Do you
Right.
call the medical board of the state medical board? Do
Right.
you report them to HR? Do you report them to who do you report? Somebody who
part
is
of the problem.
clearly not competent
That's part of the problem.
and
by the way,
dangerous
is-
and shouldn't be allowed to. Some of these people are 007s.
Yeah.
They have a license to kill.
Yep.
Some of them are serial killers.
Yep.
and yet they pervade in our system, and they move from place to place to place to place and get away with it over and over and over again. Well, how do you stop that? Because I can tell you right now, perfusion, you screw up, that surgeon says you're out of here. That's it.
Exactly.
You're gone.
You're gone and done. And no more like you're X'd off of all his cases.
Even if what you did
was
just an honest mistake. We are humans. We will make mistakes.
Correct.
I went on bypass one time and I didn't not just have the oxygen turned on. I didn't have the damn lines hooked up to the wall for the source.
Oh, wow. Okay.
And went on pump and realized it and ran really fast and undid them and plugged them in. The alarms were going off. All kinds of stuff was going on. Everybody's kind of looking around because why is Joe moving so fast? And you know what? It surprisingly enough, the blood was dark only for just a short period of time and nobody else noticed it but me. Okay? So, but that could have been, if I were not who I was, if I didn't have the reputation that I had, if I didn't know the people to the degree that I did, and they didn't like me, that could have been job ending right there and could have potentially actually been career ending, because if they pulled my privileges or reported it, that would be the end. Okay?
Correct.
Off of, I was tired. I wasn't thinking. It was busy. I was running around like crazy. And I forgot that. Right?
Right.
So, by the grace of God, go I. But you have a nurse that does something, and dude, they're done. They're done. They're done.
Yep. It's true.
I
mean,
and some of them get prosecuted. Look at what happened in Tennessee.
Exactly.
So I don't know. I wish I understood it better, but I don't know how these guys keep getting here. Dr. Bhatia says, stand by. Okay.
No, that's good.
So that's good. So he is going to take the call.
Yeah.
That's good. I think he's going to be able to shed some real light on this.
Okay,
so tell me what you think based on everything that I just said.
I mean, yeah. I mean, it's true. People, I feel there's different weights for where you are in the hierarchy,
Yeah, I believe so. It's not? Well, I didn't disconnect it.
It's not.
I'm sorry. Here, Joe's on it. Here. I'll reconnect it. Sorry. Okay. It is now. Yes, sir.
There you go.
Sorry.
So, yeah, I mean,
Okay.
obviously there's a huge discrepancy in hierarchy and accountability in the said hierarchy. That's the case not just in medicine or healthcare, but pretty much everywhere, right? I mean, that's normal. Is it a problem? Absolutely. A huge problem in healthcare, Everybody should be held accountable for their actions. A nurse, should be held accountable for her actions. A perfusionist, a physician, a surgeon, an anesthesiologist. It doesn't really matter who you are,
But they're not.
But they're not, yeah. But that we can't change, Joe. And again, it's not just our profession that's like that. It's that's pretty global, you know what I mean? That top of the food chain type people aren't held as accountable as lower on the food chain type of people, right? Like, that's just the way it is. I think it comes down to dime a dozen rule, is that the ones on the top of the food chain are not dime a dozen, whereas the ones on the bottom end of the food chain are dime a dozen.
Yep.
And can easily be replaced. How you can't easily replace a CV surgeon, right? You just can't. Versus you can easily replace a nurse because there's so many of them.
But yet there's a shortage of them too.
Oh, now there is, yeah.
There's been a shortage of nurses forever.
But can you replace them easier than a CV surgeon?
Yes.
Absolutely. See, so it's not about the shortage; it's about replaceability. That's more what it's about. Yes, there's a shortage of both, but in the end, there's only so many CV surgeons versus there's a lot of nurses you can choose from. Sure, we're short on nurses because they literally do everything.
But they could pay that one there more and get them to come over and start a bidding war then.
Exactly.
And they have no problem doing that.
So, absolutely everybody, I've always hated the fact that there's different levels of accountability, but we can't change the society we live in. The only thing you can do is like we're trying to do today is try to figure out what to do in case some stuff like that happens. You know
Well,
what I
does
mean?
anybody in the audience have any experience with this? With just basically a surgeon or anesthesiologist or even fellow perfusionist who you just know is incompetent. They're incompetent. What are they doing here working? Look, I worked with a perfusionist once while we're talking, and I don't know what your experience has been with perfusion, but I worked with somebody, and literally he truly believed that when he was filling the heart, he understood the mechanical aspect of it, but he would announce that when you'd start seeing a pulse, that he was seeing injections. Injections, yes. He really believed that. I mean, this fellow was a nice fella, but he was
It was like English as second language?
no, he was just dumb as a rock.
Injections. That's
But
awesome.
he knew enough how to turn the knobs and clamp the lines, how to not pump air. He knew enough of that, but he didn't understand anything that he was actually
That an
doing. injection
injection is literally the opposite of an ejection.
They were more than happy to have him. Okay, so we're gonna go. They were more than happy to have him do his cases.
That's semantics, Joe. That's a
because-
wordplay.
It's true. I'm not.
I mean,
no,
as long as he's
there
getting
was-
the aorta,
there was more than
aortic
that.
injections, we're good to go.
There was more than that. Am I gonna have to unmute my phone or anything or my computer? Yes. Unmute my computer. Okay. YouTube is muted. Okay. Okay, I'm calling. I don't hear it ringing. I do. I hear it ringing.
Turn up the volume.
You're going to have to turn it up. Oh, that's video. I didn't want video. Shit. I just wanted a call. So annoying. FaceTime video. I don't want FaceTime video. I want FaceTime audio. FaceTime audio. I got it.
There you go.
There it goes. Okay, it's calling. Hello, Dr. Badia?
No, you don't have an answer yet.
Calling. Ringing. Not here. It's not ringing there. It says unavailable. Okay, I'll try again.
You want to try calling me and test it out?
No, that's not what it is. We've done this before.
Yes, we have. One time me and you called Becky, we checked it, it worked beautifully.
Okay. Yes. All right, let's just do it this way.
Oh, yeah, through the phone. You can, like, keep it over there by your...
Hey, Dr. Badia, how are you?
Fine.
Good, good. How's everything going?
All good. Just got out of surgery a little while ago, and all good.
Well, we want to thank you very much for being willing to have this conversation. I already teed it up and told the audience. In fact, do you have his picture up? I hope you do. Yeah, thanks. That Dr. Bhatia is as a cardiovascular surgeon here in Houston, has been operating for 25 years. He trained at both Ochsner and at Carolina Heart in Charlotte, and
Baylor.
for his cardiac training, sir.
And Baylor.
And Baylor, that's right, and Baylor. Was that cardiac or general at Baylor?
It was a cardiac
Cardiac, okay.
and cardiac in general. It was a fellowship. It was kind of a weird thing, but yeah, we spent a year with doing like a research fellowship, and then I finished in general surgery, and then went to Carolina's Heart Institute and vascular and cardiac combined.
Oh, very, very good. But you are also a member of the Texas Medical Board, and maybe you could
Correct.
elaborate a little bit more on what your role and position is. I know that it is a position that is given by the governor
Right.
appointment. It's an appointment.
It's an appointment. It's given by the governor. That's correct. There's 9 MDs on the board, and I think 4 DOs for the entire state of Texas. You represent the state of Texas in terms of licensure and discipline, and anything that has to do with our licensees for the entire state.
Very good. And we have been discussing for the past 30 minutes, kind of muddling through it about what you do, about what is clearly either inept or incompetent, or what is not just somebody who's slow, not just somebody who maybe isn't a very nice person per se, but people that are really just shouldn't be operating for whatever reason, whether it be a surgeon or whether it be a perfusionist or whether it be a nurse or whether it be a cardiologist, an internist, whatever, it doesn't matter.
Yeah.
A licensed professional of some sort. And we were asking, the question came up, but we didn't have an answer. What is the appropriate mechanism, number one, for dealing with that? And number two, based on the fact that there is society has an opinion, and maybe to a lesser degree, but within the healthcare field, we have a very strong opinion that doctors tend to protect other doctors. I don't know that that's true. I don't necessarily believe that, but it's a perception. But I do think that there's concerns about being sued or being marked, if you will, as a person who tried to hurt somebody else, because you don't know who that person's friends were, and just because that's your opinion doesn't mean that it's true, because everybody says the same thing. I get the most difficult patients. I get the patients that are the sickest.
Right.
We always hear that story. So with all of that said, basically teeing it up for you, can you maybe share some insights for us and help ourselves and our audience with what you do if you find yourself in a position like that?
Yeah. Well, I mean, I think first of all, it all starts with the credentialing aspect of things within each specific hospital. So, in order for a physician or allied health professional or CRNA or perfusionist to have privileges in the first place, it's got to be vetted appropriately through the credentialing departments within the hospitals. That typically comes from case logs, or if you're fresh out, your training logs, things that you have kept up with along the way, and then if you are seasoned or been out in practice already, you're going to have a file, if there are issues typically, and those sometimes are protected, but I think for the most part you're obligated to report those types of things if you've been disciplined by a hospital, or say for example, had a temporary suspension. Now, that being said, sometimes they don't get reported. The next level comes to the medical board. Well, I'd say first, to the MEC of the hospital, and there are committees now that have been developed, and I think for good reasons. These quality assurance committees. Sometimes they're overkill, but for the most part, they at least shed light on trends, if you will, of potential bad players out there. And so, if it goes from there to the MEC, there's an action, that's taken by the hospital. Sometimes they can make these physicians or allied health professionals or nurses or whomever the specialty is, have a 6-month review of their performance within the hospital. And then if there's problems after that, then it can be, escalated up to the state level, which is the medical board. And if it comes to the medical board, then typically investigations happen, and a lot of the things that were protected under committee type settings within hospitals are no longer protected. They're not protected for the medical board. Typically, the board can access what they need to complete their investigations. If there's an issue, whatever the issue may be, there are avenues for which you can ameliorate or improve, try to attempt to improve physicians or whoever happens to be in the spotlight. Now, there are various reasons that physicians become, for the lack of a better word, incompetent or whatever. You can have physicians who are impaired, and not necessarily under drugs or alcohol, but even for medical reasons. And if they're impaired, then there is, within the state of Texas, under the medical board or in conjunction with the medical board, the Texas PHP, Physicians Health Program, where a physician can go to the PHP and say, look, I have a problem, I have an issue, I need some help me to get better. And that typically can protect them from, a negative action from the board, like having their license taken or whatever. Now, when that happens, they're under strict scrutiny for whatever reason. If it's drugs and alcohol, they're subject to random drug testing and, a lot of different other things to stay in compliance with that PHP. If they go to the PHP, or if they're told to go to the PHP and they're not compliant, then they can come to the board for action. Now, if it comes straight to the board, it's not necessarily an impaired physician, but it's just a perceived incompetence or perceived, whatever the word you want to use, not necessarily being within the standard of care. Then there are proctoring orders that can be given where another, competent physician would be asked to oversee another physician for the, say, 6 months or however long that the board deems is necessary, and then that report would come back to the board and say, okay, yes, he's competent, or no, he's not. There's also classes and written classes for K-STAR, called K-STAR, and that's for competency evaluation on a more of a testing level. See what, the facts and the things, like, say, for an internist, not necessarily a proceduralist. And then we can even ask that the physicians go back and complete mini residencies. And then also we can order for chart monitoring, where somebody from the board or another physician looks to overlook and see how the records are maintained and the outcomes of the patients that are being treated. So that's kind of in a nutshell 4 or 5 different ways that you can basically intervene and try to make things better when you see problems.
Mm-hmm. So let me, if I can, let me ask you this question, and it's somewhat controversial, and we respect if you can't really answer it, that's fine. But you have Surgeon X comes in and does a 3-vessel bypass with an aortic valve. Case starts at 7:30. Procedure basically goes fine. No real major hiccups. Maybe a little more calcium around the valve than they thought. Maybe an endarterectomy or 2 also needed to be done. But the case is done by 1 o'clock, 2 o'clock in the afternoon, and patient leaves the operating room under minimum support, maybe a little pharmacologic support, and goes upstairs and does fine. And then you have somebody else that comes in and does a 3-vessel bypass, no valve, and the procedure starts same time, 7:30, and by 3 o'clock in the afternoon, the mammary is just down. Mm-hmm. And you go on bypass, and the procedure, the on pump time for that procedure is 3 hours and 40 minutes. And the patient bleeds and gets several transfusions. and eventually gets out of the operating room with a balloon pump and goes to the unit and is in the hospital for 5 to 7 additional days from the other procedure, which was more complicated. And this is a routine thing that this happens all of the time. But yet the patient does eventually make their way out of the hospital alive.
Yeah.
What is the position of the cardiac surgery community at writ large about that? Because clearly, and when you see this, when it happens once or twice in a year or two, well, sometimes you just get bad luck.
Yeah, bad
We
targets,
understand
whatever.
that.
Yeah.
But when that's a routine, at what point does somebody who is responsible to say this is absurd?
Yeah. So, I mean, that has to start at the local level, which would be the QA committee, the Quality Assurance Committee, or CV committee within that hospital. And at some point, they look at, they have to look at the overall outcomes, and they do. But unless there is, typically a perceived increased mortality, I mean, yes, there may be some more morbidity and whatnot. If you can have a trend, then again, it's up to the hospital to take an action to say you have to, improve your outcomes or else. And that's a very hard thing to do sometimes.
Why is it so hard?
Well, I mean, there's a lot of whys, but I mean, if you give somebody privileges to operate in a hospital, you have to have real solid reasons to take them away, I guess. And there's a lot of legal implementations of that, and a lot of things that can be inferred from that, and the hospitals typically don't want to put themselves at some sort of risk. And so, yeah, I mean, it is hard to watch sometimes, but, it basically all has to do with the overall outcomes. And, unless there's a higher mortality, then it's hard to pin something on somebody. Because, there are, in any aspect of medicine, especially the proceduralist side of things, there are people who are just gifted with better hands and better decision making or whatever. And so, you're going to see these variations in overall outcomes.
Yes, that's true, but
however, I will say that if there's perceived damage, that the public's not being protected, then of course your option for anybody is to just report that to the board and say, hey, look, I'd start at the hospital side first and say, look, this is our concern, and this needs to be looked at, and anybody should be able to do that. And then if the answers aren't, necessarily provided that way, then it certainly anyone's obligated to report if they feel that the public is not being protected.
Well, I mean, I did talk, we did talk, and this, of course, doesn't involve you. I'm just talking, in general terms, but I have had experience with working with people that just, I mean, the public was in fact being harmed, and nothing was being done. And so what is the appropriate mechanism? So if you're nurse Susie Q, or you're perfusionist doofus extraordinaire like me, what is the appropriate mechanism by which a concern like that should be reported? Who do you report it to? Do you go to the board? Do you go to the hospital QA? Do you go to another, let's say, a colleague or somebody that's a lateral to this individual? What do you do?
No, I don't think that you shouldn't get other colleagues involved if you can help it. the channel is different at each hospital, but I think that you start with the QA committees and then see if that doesn't go, then we can do, what I'd said is just try to have somebody, suggest that in the form of a complaint, to the board. Not that I don't want to encourage people to file complaints on physicians, but I mean, you got to do it at the hospital level first. And then if the result is not what one might expect, then the board is the next way to the next venue, I guess, that you could approach. And
Sure.
anybody can do it. It's not it's not a only one type of specialty can do it.
But of course, you have to, I know that the Texas board, and I'm not sure if that's the same in every state, but you cannot file any kind of anonymous complaint. It won't be accepted.
You can in Texas. You can.
You can?
I'm not sure what it is in other states, but yes, you can do it anonymous, and it stays anonymous. 90% of the time. There is one point that if it went to a full-blown trial, which would be 6 or 7 different things down the road of the board complaint, that the complainer, the one who files a complaint, would have to unshroud himself, but that's so far down the road. But in the state of Texas, you can choose to remain anonymous. I think it's probably the same in most other state boards as well.
Well, Samir brought up, the very first thing he talked about was Christopher Dunch.
That guy was
And
bad.
how in God's name did Christopher Dunch last as long as he did to have killed so many
He
people?
worked at like 4 or 5 hospitals,
Yeah.
different ones.
How does that happen?
That's a whole nother discussion. I was involved in that, and I don't think that we should really get into that right now. But there were a lot of mitigating circumstances and factors. But in the end, the board took the appropriate action. That's for sure.
Yes. Well, the board and fortunately the district attorney.
Yeah.
Right.
I mean, he's in jail, right?
He should have done. Yeah, he's in jail for life. Isn't
For
he in
life.
jail for life?
He is. Yes.
Yeah.
So there you go.
Had he done it in Los Angeles, he would have gotten the key to the city. Gascon would have
Oh,
just
God,
let
Joe.
Gascon would have just let him go.
Lord have
They would have
mercy,
just
Joe.
let him go. They'd have given him a prize for thinning out the population. Dr. Body, I can't thank you enough for taking your time.
Yeah.
I know how busy you are. It was nice seeing you today. Nice job on that case.
Yeah, you didn't have me today, Dr. Body. I see Joe came back.
Yeah, Joe was there to help guide your hands. I worked very hard at that.
Exactly.
I do think you did a really good job on that case, but I still hold that the patient would have done so much better if you'd just gone on pump.
Okay. Well, I don't know who your audience is, so I'm going to refrain from comment.
All right, I'll talk to you later, sir. Thank you very much.
See you later, Dr. Body.
Bye-bye, sir. Bye. So that was good. Yeah, it's a complicated issue,
Yeah, it is.
and
Very
as you can
complicated.
see, as you can tell, it is a political issue.
Absolutely.
It is like a hot potato. It's a grenade. It's whatever you want to call it.
Absolutely.
And nobody wants to be holding it when it's going to go off.
No, I mean,
Everybody's afraid of being sued.
Yep.
Everybody's afraid of being marked. But
Yeah.
I understand his need to be neutral to some degree. But you're not going to convince me that it is reasonable
Yeah.
for a case to take 16 hours to do
A 3-vessel cabbage.
a 3-vessel cabbage. No, I'm sorry.
No.
It's not.
It won't. Yeah. I don't
It's-
care how bad
it's-
the targets are.
It doesn't
Like,
make any
yeah,
sense.
It doesn't make any sense.
For that to be a routine.
Sure. Yeah.
And that's a concern, and
Yeah,
you see it.
absolutely.
You see it in a lot of places. It's not isolated to any one place.
No. Yeah.
And
mean,
you
it's. I feel like you're always gonna see something, right? Like.
yeah, but there's something and then there's something.
Yeah.
Okay. There's
I mean,
something
it's-
and there's something.
I was just about to say there's like there's a big difference between that one time happens once in a blue moon occurrence to it's always like this.
Yes.
You know what I mean? And
Right.
there are people that it's always like this.
And if
you
they
know?
don't have the skill, if it's not fair to the patient, it's not fair to the community. Why is the cardiologist referring this person cases? Why is the hospital permitting it? Why are they not intervening
Absolutely.
and saying, you know what, you're going back to another fellowship, okay?
Yeah.
You are not ready to be doing this, or
Yeah.
you're going to have to work with another surgeon for some period of time until that surgeon says you are qualified.
Yeah, like first assist them.
Something.
Yeah.
But they don't.
No, they don't. I feel it's a little bit like Dr. Bhatia kind of alluded to that, you know, it's difficult when you're given the privileges to take them away.
Right.
You know, he did allude to that when he
We're
was
given
talking.
privileges. We're privileged.
But they'll take ours away in a second.
Yes.
You know.
Yes, but you would still have you would still be guided, and they would still be guided by the same bylaws.
Right.
But we don't have the deep pockets.
Oh yeah.
The
for
deep
sure.
pockets, because you saw that on the salaries, right? And so, you know, we don't have the money to fight something like that, where somebody who's a CV doc probably
Has it.
making, they're probably making, I would say 400 to 600, maybe up to 700 salary, I imagine, is probably where they're at. Depending on their RVUs and stuff, they're based
Yeah.
probably around 350, somewhere around there, but they're pulling in 500 pretty routinely, I would imagine.
They can easily get up to 7.
Yeah, I would think so. Because I know that if they get a job like getting paid 1.3 million, they jump it. They're like, I'll take it.
Yep. And they'll move to wherever for it.
Yes, yeah. They will. There are
yeah.
places that will pay that
Absolutely.
just because there's such a high demand
Yep.
and shortage of
Yeah.
cardiac docs, and they
Especially
a lot
in rural
of,
areas.
and a lot of the really good ones don't want to go into it anymore.
No.
They just don't want to do it.
Yep.
It's just
That's the
they're
case.
taking a pounding, and it's
Yeah.
very different. I think ultimately, I don't like the employee model. I think it should be I think you should live and die by your availability and your ability.
I agree.
And I think that if you are not being paid a salary and you're required to basically take care of these patients, do everything you need to do, and do the cases well enough so that you will get. So you're taking that long to do cases, and somebody else is doing 3 cases to your 1.
Oh yeah.
But if you're getting paid a salary,
Yep.
what do you care?
Exactly. You're gonna make it regardless.
And this is the fundamental problem. We don't have and that's the thing. But then on the other hand, for example, let's say people that work for us, for HET, there are many people in this organization that they want to be employees. They want to have the protection of a salary when there's problems, or they want to have the benefits and the taxes and the vacation time. They don't want to have to worry about it.
Yeah.
And they want that model.
Sure.
But then there's other people who are like, look, I'll do 3 cases a day. I'm going to make money doing it. Okay. It doesn't benefit me to do that if I'm not going to
Salary.
get anything different.
Yeah,
How does
yeah.
that make any sense?
Right.
Right. And
Yeah.
I understand that.
No, yeah.
Right.
Yeah.
So what is the right answer? What's
Yep.
the right answer? And how do because that's how you improve quality.
Yep. That's why I don't
'Cause-
envy your job, Joe.
You can have it. You got 10 cents? I'm selling the company today. In fact, you don't even have to give me your watch. I'll just take these 2 bracelets.
Oh,
That's
no.
good.
No, those are my
I
lucky
could-
bracelets, Joe. You don't get those.
I get the bracelets, or you don't get the company. All right. Okay. Let's call Debbie Adams and let's jump right into, is the perfusion staffing crisis over? I don't necessarily feel that we solved anything on that session, but I think we at least did have a decent conversation, and probably
I agree.
a conversation that needs to be had.
Yeah.
Because there are people out there, people that may watch this now, that are watching it now, or may watch it here in the future, that don't know what to do.
No,
and they're working with somebody who is just absolutely shouldn't be doing this.
In defense of our content, if in that hour, that solution is not actually solvable per se. There will, like Dr. Badia also said, every hospital will have its own thing. First off, it's easy for us to say, you got to do this. Well, that works for our hospital, whatever X hospital, but it won't work for Y hospital. It won't work for Z hospital. It won't work for A hospital. Each one of them is going to have a different hierarchy of structure, so there's no real answer to the question. All we can do is try to, steer the crowd, at least inform. I feel we informed. Again, it's not our job to answer. At least that question. That's a hard question.
Well, I'll tell you what, if you're the public watching this case, what you should find out is what not only how many cases the person, not only how many cases does this particular person do, whatever their discipline is,
right?
But what is their time, their operating room time, as compared to another surgeon or other surgeons? There's so many questions that should, and I see,
and that's just the operating room, and then how much ICU time do they have?
But you have to be fair, because there are some people who do take some very challenging cases.
Oh yeah, absolutely. And, for sure. That will take on the hardest of hard cases, aortic cases left and right.
Yes.
Root repairs like it's nothing, and those are not. I'm sorry.
So you have to be fair.
Yeah, absolutely.
But then I've also seen, I've seen people take on cases they shouldn't take on. They just shouldn't do it.
Yep.
Like, why are you going to do this procedure? You've not done one of these. You've never seen one of these. Why are you doing this? As opposed to, why don't we send this person somewhere else?
Yeah,
if you want to do these kind of, you're never going to see it again.
Yeah.
You want to just say you did it, but is that really in the best interest of the patient?
That's always, I feel like that's a hard part to deal with, because they also want to try to better themselves. You know what I mean? And how are you going to get better unless you take on that first case? You can't avoid it. But I get it. Maybe you should be a little more selective. You need to know your own personal limits, right?
I agree. Would you agree? Would you agree that I'm kind of a cocky dude?
Yeah.
I've got some swag, what's the word? You got swag, not swag. Some kind of, I got swag. I know what I'm doing.
Yeah.
I've got that attitude. I've got that right. But
very much so. Yeah.
But I got
especially in the OR. Lord have mercy. You're like,
it's like
you're a whole different beast. And he's like, you
like
got to see this man in the OR.
But we got a call just recently about an NRP case on a 4-month-old.
I know. Yeah.
And I was like, whoa.
Yep.
Okay. No,
Heard about this.
It's not going to be 3/8 inch tubing.
No.
1/4 inch tubing.
Then we're not doing it.
Cannulas of sizes that I haven't ever seen.
Yeah, they come really tiny.
I did pediatric, back when I was in training, but that was 45 years ago.
Yeah.
I have I do not in any way feel comfortable with this.
No, not at all.
And so, but I could have been arrogant. I could have had no humility and said, sure, I'll go do it. I can do anything. No, I can't.
Yeah.
And I think that's lost in some people.
Oh yeah. They would have tried to tackle it.
You kind of got to know your limitations.
Yeah.
But every one of our group, actually, because there were several people that were involved in this, and everybody said, I don't think so. Because I said it first. I was like, I do not feel competent to do this.
When I heard
a 4-month-old that's going to die,
yeah.
and we're going to let die, circulatory death, and then take their organs, which are going to be pristine likely, because this is probably some anoxic head injury, anoxic brain injury, or it's some kind of anomaly that made them so that they hydrocephalus. I don't know what their problem was.
Yeah.
Doesn't matter, but their organs are probably going to be great. And there's kids that are going to need them. I am not about to go ruin them.
God, no.
Okay, no.
Yeah,
And
not
so,
at all.
but I deferred. I mean, I deferred because that's the right thing to do.
Absolutely, that's the right thing to
You
do.
know?
When I first heard about it, I was like, oh God, I don't want any part of it. I
No,
knew that. I
no.
was like,
But
nope.
I think that there are some people that need to learn to do that a little bit more.
I agree.
You don't know,
Yeah.
call somebody, see if somebody can come help you if you really want to learn.
Right.
Get somebody that's done, and that whether you're a perfusionist, whether you're a nurse, whether you're a physician, surgeon, whatever. I mean, just do what's right.
Yeah.
How about that?
Try to stay in your own lane. Again, know your limitations. I feel that's huge.
I agree.
That's when we get ourselves in trouble, right? When
we
try
do
to,
very frequently.
when we think we're better than we actually are.
No kidding. Exactly.
That's
Now,
the
with an
number one way.
adult,
Have at it. Bring it all on.
bring it on. I don't care. I've seen everything. There's nothing I haven't seen yet. There's just literal. I do not believe there's anything I haven't yet seen.
Right.
I don't. Now,
Seen it all.
maybe adult congenitals.
Yeah, those.
Because I'm not going to like, what's this anatomy doing?
Yeah.
I might have to think through that a lot. I'd probably ask for help.
Yeah.
But just a non-adult congenital, whatever the problem is.
Adult congenitals can get so tricky with like collateral circulation,
Right.
and this
See,
and
I would
that,
get-
macas here and there.
I would
and-
get messed up on
yeah,
that.
that's tricky stuff. It's
Okay,
tricky.
I'm gonna put a call in to Deb Adams. We're gonna start this up straight with her, and this is gonna be on: is the perfusion crisis over? And if so, what will be the consequence of that? Because I'll tell you right now the way I view it. You have a pendulum. The pendulum is always swinging back and forth, back and forth. Shortage of perfusionists, salaries are going up. It's somewhere in a sweet spot. Glut of perfusionists, salaries stabilize or maybe contract, and you have loss of staff, and then come back this way, and students can't find jobs, and people are trying to move somewhere, or they're not any good and they get cut and they can't get a job somewhere else. They go into a different industry, and then it comes back again and does the same thing. And this is cyclical over time. And what I've learned in my years of doing this is that the farther it swings this way into shortage, the harder it swings back and the higher it goes into glut. So if it's only swinging in here, it's not too bad. But when it comes way out here, it's going to go way up here. And right now, my view, this is my view, is that pendulum is swinging from major shortage, and it is on its, and it's been way up there, like higher than the screen. And it's coming down, and it's coming fast. And I think we're right about here. We haven't made the middle point yet. We're still, I think, before the sweet spot. But that sweet spot, the time through it is going to be very, very short. And it's just going to woof and go up like this. My view is there's a bunch of schools being started. My view is they're graduating people just like they turned on a faucet. There's a perception that the workforce is going to be retiring sometime soon. It really isn't, because people don't, I don't care that they're 50. That's still 15 years of work they're going to have to do, okay, just to retire.
Yep.
And
Plus, we have a
retirement,
job that you can do until late ages.
yes,
Because
and
we're sitting most
correct.
of the time.
Well, you are. And then retire, you
I
are.
like it. I enjoy it.
I know you do. We got to get you a padded chair and retire, and so I think there's going to be fewer and fewer retiring. And again, COVID revealed that issue.
Exactly.
People
That's what
were
created
close
the-
to retirement and said, I'm out. I'm done right now. I'm not doing this. And they got out of it early. But I think you can't just say what workforce, going back to that specialty care thing, which again, it's business. I get it, even though it's written very poorly, which they should really correct that, okay? I mean, if you write stuff like that, that's your website, I'm concerned. But that's a different issue. I'm not going to call them and tell them in case they're watching. Al, stammering stammers. Al, stammering Al stammers. And Kurti Patel. The two, you want to talk about two doofuses. Those are two doofuses. But you basically, you have this issue, and I think that that you can't say what part of the workforce is over 50. You really have to say, well, who's between 50 and 55, who's between 55 and 60, who's between 60 and 65. That's where your real vulnerability is. But if the number of people, so you have 40% over 50, but if 30% of that 40% is between 55 and 60, you have a much bigger problem than if only 5% are between 55 and 60 and 30% are between 50 and 55 and the remaining between 55 and 60. That's, I think, my point.
And you forget the new, every year we're graduating more and more people, which is diluting out the complete pool.
Correct.
So that 30%
And then
is
making
also coming down.
And then making a younger workforce.
Exactly.
Which is going to be yet another problem.
Exactly.
Much in the way airline pilots.
Yep.
You have to work for the airline
Right.
until you're almost at retirement age before you get that coveted left seat transoceanic or
Exactly.
intercontinental, right?
Right.
Yeah, exactly. That's the issue. Okay, Debbie Adams. So I've teed it up. Now we're going to go with Deb Adams. Call. You getting it? The same way. But I don't know if you're getting it. I don't hear it ringing. No, through the phone. Oh, hey, Deb. Hey, Deb, hold on. I'm sorry. Hold on. Don't hang up. There, that's what I had to do.
Did you move?
Okay, is it working now? No, I can't hear it either. I'm trying. Hey, Deb. Yeah, hold on. I'm having challenges here.
Joe.
I know. I'm a mess. Let me hang up and call you back. I don't know why it worked before. It doesn't work this time. Everybody, I'm sorry. Need to find Debbie Adams. Am I still connected?
Yes, I see you.
Hi, Lord have mercy. New FaceTime, no. Day.
That little icon next to it. Yeah, you did it through there last.
No, I didn't.
No, he didn't. He did it through his phone. It didn't work through there.
Yeah, just trust me.
Yeah. He tried and then he couldn't hear it.
Okay. God bless America. I just don't understand this. Let me see. What am I doing wrong? Okay. Now, let me. Okay. Is it
Try
ringing?
putting it on Joe's iPad?
Hello?
or-
Wait, is it? No, it's not this. Okay, forget it. Speaker. We're going to go this way. Deb, can you hear me?
Yes.
Okay, can you hear? Is it working? I have a microphone on it. David?
You want me to say something?
Yeah, say something.
Hello, Joe. How are you?
Good. Okay, and so we have Debbie Adams on the phone. Debbie, as you know, is the director of the Texas Heart Institute School of Perfusion. Are we going to put her up, David?
Yeah.
Okay. And that's all right, I'll just hold this. I'm good. And I wouldn't worry about that. And Deb, we sort of teed it up already, kind of talking about where we were in terms of a perfusion shortage. And, I kind of gave my example of the pendulum that swings back and forth and all that stuff. And I was wondering if maybe you could give us some insights on where we are in terms of training programs, number of students that are being graduated, whether or not you see the number of perfusionists going up, where people are not, the job market is shifting from it being essentially a buyer's market to a seller's market, so to speak, where the buyer would be the perfusionist and the seller would be the employer.
Right.
or and how you see this, where you see this going over the next, let's say, 10 to 15 years, especially for the
Okay.
younger generation.
Okay. Well, first, Joe, I want to thank you for asking me to join you. So thank you very much. It's always a privilege. I'm not really sure who the audience is, but I assume it's a mixture of employers and students that are looking for work and the perfusion community. But this is a question that the program directors council, all the program directors from all the schools have on a continuous basis, because we want to make sure that we are training exemplary students, but as graduates we want to make sure they can get a job. And as you know, those of you that, like Joe and I, we went through a situation back in the late 80s, early 90s, where there were a lot of schools. Like, I think it was close to 40, and it got to where we probably had saturated the market, and it was difficult to find a job. So it's a question, but it is supply and demand, and we can't control, we can't say, oh, we're not going to train students, so we leave them the market, unsaturated. But I can just tell you from graduates from this year, so the schools share information every year when we meet, and we just met in May, and as of so for the 2024 graduates in admissions, for 2023, all the programs, and at that time there were 21 accredited programs. Now we have 22 accredited programs. Emory just became accredited in the spring of 2025. We graduated 276 perfusion graduates in 23. In 2024, there were an increase of admissions to 312 students. And we have one additional school, which is the University of Southern California, which took their first cohort this fall, and they have 8 students. So the projected growth for 2025 would be 31 students. So we've increased, about 30 from 23 to 24, and it looks about that way. But then if you go back and look at number of new certifications, if you look at the board information for 2024, they had certified perfusionist of 235. So 235 in 2024. So the total number of CCPs in 2024 was 4,988. And it's been steady for like the last 4 or 5 years of adding about 230 new perfusionists.
Can you give me that number again? 4,000 how many?
4,988 total CCPs as of the end of 2024.
So I can tell you that in 2018, the last year that I did the New Orleans conference, there were 4,630.
Right. So it's been going up about 100 a year for the last 5 years. But in the last few years, like in 2024, there were 90 certified perfusionists that lost their certification for whatever reason it was. They retired, they didn't want to, they didn't have cases, whatnot, and about 112 that filed for extension. So out of those, so we're at kind of a, instead of adding 200, we're probably adding more like 100 every year. So, we're always feeling like, when are we going to get to the place where we have too many? But I can tell you from just my graduates, I took over the program in 2021, all of our students, 100% employment. And my last 2 classes all employed before they graduated. I had one that held out, and they had several job offers, but didn't actually take a job until like 2 months after graduation. But that was because of their own choices, not that there weren't jobs. what I'm seeing is that it's a little less of saying, oh, I want to live in Houston and there's 10 jobs. It's more now of people having to, there's jobs all over, but now we're starting to have there's jobs, but you may have to, how it was where you may have to relocate. You may have to move to, North Carolina for a couple of years before you get to come back to where you want to live for your career. So that I'm starting to see a little bit more than, a few years ago. But there's still, there's, 2 or 3 jobs for every student that I graduate, and 100% job placement for every single school. And you can speak more as an employer about, is it harder to recruit, and their salaries are still, and again, Joe and I started a long time ago, so we started at like under 25,000. But these graduates are making, it's supply and demand. The salaries are really, they're very competitive. The salaries are still bad, and I haven't seen where salaries are flattening out or going down since I started really paying attention to it in 2016. So
a couple of things that we discussed in an earlier session was the expansion of services vis-a-vis ECMO becoming more and more and more mainstream, and whether or not that will shift over to another provider vis-a-vis ECMO specialists more often than not, and also NRP, which is a new service, and we see that as being something that's going to be time consuming for perfusionists. You're going to need more perfusionists to cover a new service line, which I think is going to be around for many years to come. I think at least 10 years.
Yeah, I think the NRP is going to really expand job opportunity. But again, people are going to have to, it's just like when we started back in the early 80s, and I say we because you and I we're in the same generation.
You're younger than I am, though.
Well, a little bit, but we're still in that little box. We can't give things away. The NRP is a perfusionist responsibility and role. We are the most qualified clinician, in my professional opinion, to do that work, and we should not allow it to be done by somebody that's a non-perfusion trained person.
Oh, I agree with you 100%.
And so we're going to have to man up for that because I don't think the demand's going to go away. I agree with you. And so we're going to have to figure out how we're going to cover that. And it may get painful for some until we can make sure that we have enough, clinicians trained to do it. We are going to move more out of the OR theater into just like we have been. We're in the cath lab more. We're going to be outside of our comfort zone more. And I think that's exciting. I think there's lots of opportunity for future perfusionists, but they're going to have to, they're going to have to take advantage of those techniques. It's not just going to be pumping a case and, cleaning up and going, and ECMO, I don't know. I mean, it just depends on the center. There's still lots of places where it's very perfusion driven. And so I think that's and it's getting more and more complex. I mean, some of the stuff that they're doing here, it's a lot. It's a lot of, you have to know what you're doing. And so I think somebody watching an ECMO versus, we got to stay involved, I feel like. I think my team was a hybrid team at Memorial Hermann. I think it was great. We had perfusion expertise, we had nursing expertise, we had respiratory therapist expertise, but you got to stay at the table. You can't just say, oh, it's not my responsibility, that's somebody else. I don't want to.
Right.
I don't want to participate.
Right. I do think that's an issue. It is a problem because that will kill the profession. You will not only have a shortage, but you will have a glut. You will have a massive glut, and of course, it's hard to say what people are going to do. But so I'm really interested to hear this because my view is that the pendulum went way out and that it's coming back really fast, and that we're just about to enter the sweet spot zone, so to speak. And if we don't have continued expansion of services, and we don't have additional types of procedures that we are responsible for going up fast enough, my view was that pendulum was going to really swing way out far. But it sounds to me, in listening to you, that that may not really be the case. My view can be wrong, but I will tell you that from an employer perspective, which you mentioned, which was a very good point, I can tell you that it is much easier to find people that want to come to work than it was before. I've actually had the opportunity to tell a couple of people now, just a few, but a couple, that I'm sorry, we just don't have any positions available right now. Now, that can be because, I mean, and please forgive this very, what's the word that people use? Selfish. This very selfish plug. But I think that, I think HET is just a really good organization to work for, and people want to work here, and we're not losing people because it's a really good job. And I think they have I think they have great leadership. Not that, again, plugging myself, but that's really how I feel. We do a lot of really cool stuff. We have perfusion assistants. They set up, they tear down, they reset up, they
run your blood
gases. They're there to help you. With NRP, we always send an assistant with the perfusionist to do those cases. Perfusionists don't do cell savers. That's all auto transfusion driven. And I think that, I've been doing this job so long that I feel like I've built a company based upon the things about the profession that I always wanted to make better, but didn't have the power to do that. So I've tried to do that. So in some ways, although I understand that was a very selfish plug, and I appreciate that, and accept that as what it is, but is that maybe the reason that I'm viewing this the way I am, and that there are still jobs out there that people are saying, I don't want to do this, I'm leaving and going somewhere else. They have that mobility, and it makes somebody else look like there really is still a shortage. Is that possible?
Yeah, I think that we're starting to move back towards a more balance. I would, I know I don't have the data. I know Jeff Riley, God bless, rest in peace. I know he had done a lot of research on when we were going to actually swing back to that, and I don't have his data. I know Bruce Searles and Ed Darling at SUNY, they may have access to it, but I think I'm paraphrasing, that it was going to be in the next 3 to 5 years. I think COVID messed that up because that was a few years ago, because the money got crazy for some of us elders. And so it was like, I'm going to work a few more years because now I'm making crazy money. And so some people that may have retired a few years ago, I think pushed that a little further out. And so that might have held that off for a few years. So I think you're right. I think it's getting a little bit more selective on the employer side, but I still feel like every graduate has plenty of opportunity to get out there and get themselves work. And, and again, I don't think, not as much of, there's 5 jobs in the Texas Medical Center. I can, I might have to go to Corpus Christi before I can move back, or, but I think they can get work, but they're going to have to be willing to move. And so that's more like it was, maybe 10 years ago when people were starting. But the salaries are still pretty, competitive. I don't see them going, and that's what happened, in that late 80s, early 90s. The salaries tanked too, because we had
they did.
We had way too many clinicians.
They did.
I don't want to see that happen. I just, I think there's lots of exciting work out there. It's just going to be a little different, and ECMO still is going to be, that's to be determined, but the NRP thing is going to be huge. Adult congenital, I mean, that's going to be a whole subset of an expertise that is coming, and those are going to be complicated cases. So then it's like, is one person enough? Do we need two people? Do we need to start pushing more towards that model of N plus one, two people, that are trained as perfusionists? So,
Well, my view I have very strong views on that. That can work in in an institution per se, but it's never going to work in a private practice setting.
No, it has. I think every institution needs to determine what their, what is going to fit their model. I don't think we can all plug into the same peg or peg into the hole or whatever it is. I think institutionally your practice is different. In the practice, at Baylor St. Luke's, the medical center is different than,
St. Luke's, the Woodlands. Yes.
Exactly. Right. And so I totally agree. It wouldn't work. I mean, it's the,
it can work, but they would have to accept, and it wouldn't make sense for them. They would have to accept the cost being passed along.
The business model for the hospital can't do that.
No.
I mean, if you start looking at that end of it, you got to run it like a little business, even if you don't work as a business. Even if you're working for the hospital, you got to treat your cost center like, it's your little company, and you've got to make the margins. Yep. And you can't do that. It just it's financially not going to happen. So then it's a matter of, do you keep that service line or not? So
now I know
I agree. I don't think it works everywhere.
Yeah, I agree. But I think I appreciate that. But I also know, Deb, that you have a pretty good pulse on the international market. What are we seeing there in terms of other countries and their ability to provide perfusion services for their heart surgery programs, NRP programs, and ECMO programs?
Well, I think they're probably a little ahead of us as far as ECMO, from what I can see, because of ELSOs in the year. And again, I think those are questions for our colleagues that work internationally, because I can't. I don't know that. I do know of the countries that I have colleagues. It's more of being going through the process of being recognized as a profession, establishing, formal education, getting, credentialing, setting up standards, and then training the trainers so that they can bring the level and the quality of their care up to what they perceive to be the gold standard, whether it's, the European model or the Canadian model or the United States model. But, I think some parts of the world are a little behind where we are, but that's where their goals are, and they're doing great work. So, I think, Africa, obviously, we've got a lot of work to do there, and I think people need to, get on board to help, train clinicians that want to work in centers, to work in the countries so they can build their heart programs. So I think the Middle East has lots of work to do. But they've got great clinicians, and a lot of them are physicians. So it's kind of like how it was in other parts of the world before we trained. They're doctors, and now they're sitting behind the pump. So
that's how we started.
Yeah,
that's how we started, right, in this country. And they were like, "No, we're not going to do this. We need these other people. Hey, you look like you'd be good. You're a good fit for perfusionists."
That's how it started.
I know exactly how it started. I was there at the time. But so let me ask you this, if I can. It's kind of off this subject per se, but I think it's worth kind of having the discussion anyway. And that is, in the employee-employer model, whether you work for a hospital institution or you work for a contract company, whatever, you are paid a salary that is predicated on the amount of work or billable services that your employer anticipates that you're going to produce, right? And somewhere along there, there's got to be a profit, and that profit margin can range anywhere from 5% to 100%, depending on how good you write your contracts or how desperate the hospitals may be for a service line. So that's kind of how that works. But one of the things that we discussed was that if if your job is a salary, and unless you have just an inherent kind of an innate need to do this job, be really good, produce, have exposure to things, work harder than everybody else, because there's people with that mentality, right? And they just want to do that. But there's a lot of people that are the opposite, and they're like, I want to do the least I possibly can to make the most that I can. And surgeons are in the same boat right now. You're getting hired as a cardiac surgeon. 90% of them are employed by either a hospital or a hospital system, right? So the days of the gunslinger are more or less over. But has that actually helped? And what is your view or your opinion, really, I'm asking just your opinion, about work-based payments versus being paid just a general salary? In other words, you're a clinician, you're a director of a program, so you're in a different position. But I'm talking about rank and file clinicians. You get paid to do per procedure, you get this much, you get paid if you teach, you get paid if you do this, because that incentivizes, because there are some places that the perfusionists that are on staff don't want to do any teaching. They don't want to teach anybody. Or they'll do it, but they don't really do a great job of it, and the students don't like them, and they don't feel like they're really getting anything from it, but they're still doing it because they maybe get an extra something in their salary. But if it was competitive, then you would really change the whole paradigm of who is and stays a perfusionist, where, and what is I'm just curious what your opinion is on that concept.
Well, I think it would be a good model. Then people that have, then you can start off, you have a base, and then if you want to be more productive, then you're compensated for that. And then when you want to go back to not having to do that again, then you can flex back into just your base. I think it would have to be fair and equitable so that everybody has an opportunity to be able to get that extra earn, I guess, for whatever you want to call it, so that so how it would be structured.
But should it be equitable, or should it be predicated on your availability, your accountability, your capability, and everything else? In other words, if you're not getting the cases, because, or let's just use students for example. Students say, no, I really don't. I just don't feel like this person is a good instructor for me. I don't like them. They don't do a good job. I don't feel like they're, and that's a common thread. Then they don't get students, and so they're not able to get that money. How can you make it equitable? Because if you make it equitable, then you're still taking the incentive away to be better than anybody else. It takes that competition out of the equation.
I agree. You've got to have quality. You can't just you can't be inadequate. But I think you still need to have the opportunity to be able to if you want to do it, to be able to do it.
Mm-hmm.
It can't be. there can't be a bias where I get to do it because I'm your favorite,
right?
Somebody else didn't get to do it, because then that's a morale buster. I think it needs to be fair.
Yes, I agree with you there.
If you have a really good team where everybody's watching out for each other's back, then it works. But that's a hard model to put together.
It is very, very hard. It is a hard model to put together, but I personally, of course, if it's me, it is personal, so it's redundant. I understand that, but I believe that's the most effective model, because I feel that it forces people to that want more to do more, instead of encouraging or enabling people that want to do less to do less and not have to suffer any financial consequence to it, while everybody else picks up their load.
Yeah, I that seems reasonable, because that a morale breaker for your team, and then that just infiltrates the quality of work of everybody. We're human,
Yes.
we can't help it. So
I know,
we
pesky.
can only be intrinsically motivated so much, and then there has to be other things. But I think it starts off with you need to be able to give 100% of what you have, and not everybody's 100 is the same level, and so we need to make sure that everybody's given their 100. You bring your A game every day, and that is your capacity, and then you incentivize people that you're a rock star and you can do things I can't do. Then I think that's fair. But I can't be mediocre just because I want to be lazy, and that's not fair.
But we do encourage that. We do allow for that.
Well,
and
then
especially
we need to
with
do better.
especially with the shortage of perfusionists, I know as an employer, I have in the past had to accept it. I was happy for whatever I could get.
Okay, then I'm gonna be a little.
Yeah,
as a patient, do I deserve that?
No.
So then we're not doing our job.
That's correct. I agree with you. They weren't graduates from your program, so you're in good shape.
Well, they might be graduates from, and then I'm still responsible for that. I'm an educator, and we're all educators, and we need to bring all this up. That it wasn't
their ability. It was their expectation that we know that COVID, the proverbial shit hit the fan, right? This is my last program in this studio, so I'm cursing a lot today.
I noticed that.
And there were a lot of people. In fact, you're our last guest, believe it or not. You're our last guest.
Yep.
On
no
the,
way.
Yes, the
it
last.
Can't be me.
It is the last guest in the old studio, and I'm going to make you the first guest
in the closing
new
minutes.
studio. You're closing it out and opening the new one. But because I think it's a fascinating conversation. But there were a lot of people who graduated, came out of school, and their expectations were that they were going to work 2 or 3 days a week, 6 hours, 4 to 6 hours on those days, take 20% maybe tops on call, and they were going to just be able to enjoy their pool parties and everything else, making a bunch of money.
We had one in our class that was like that.
Yeah.
Yeah, that had that same expectation.
Yeah, and it's just unrealistic. It's kind of ridiculous, and there was a lot of people that had to suck it up, including me, as old as I am, just to make up for their lack of interest. And it wasn't that they were an incompetent clinician. They weren't hurting anyone. They weren't doing a bad job. They just didn't want to work. And when we were as desperate as we were, I had to just accept it, Deb. I had to just say, if I can only get 10% of that, 10% out of this person, I've got to take that 10%. And they were still making really good income. But I was in a desperate situation. There was very little I could do about it.
Well, I don't know how to respond to that, other than we probably need to dive deeper into what impacted that, not just their effective behaviors where they didn't have a work ethic or a desire to want to serve at that level. And that if it was during that COVID period, I think there was a whole lot of PTSD and mental health issues and trauma from all of that I think we all had or still have, and we aren't even aware of it.
Yeah, but Deb, I know as well as you do. I know what you did. I had PTSD too, but there's no crying in ECMO. You got to
I
go to
know,
work
but
and do your job. You've signed up for this. You were a volunteer. Nobody drug you there, kicking and screaming, and put you in perfusion school.
that's true.
Maybe
I
they
didn't know
didn't
better.
me,
I
but-
didn't know better.
Yeah, me either. Me either. They, you know.
I don't know the answer to that, but I think we as a community and as a profession need to we need to hold our bar high. And you know, I love this profession. I love the people that are in it. I think we
Me
are an
too.
extraordinary group
I do
of allied health professionals, and I don't want us to lower our standards. This is you know, we keep it at the highest level, and for our patients, for our community, for our physicians, for each other. I mean, wimps need not apply. That's, you know, that was our motto when my team at Herman. Wimps need not apply. You can't
That's right.
do it, you know.
Right,
Move
exactly.
over. So,
Exactly. But they do, and they get in because they interview well. I mean, it's
Well-
almost like the guy that interviewed, I don't know if Samir knows this story. I'll tell you the story real quick. Deb knows about the story. This guy interviewed, and all the interviews were being done remotely because of COVID.
Mm-hmm.
And this guy was incredible, just an incredible interview. It was perfect. Everything about this guy was perfect.
Sure.
And they were like, this dude's in. I mean, there's no
Yeah.
question about it. And he got the position and he showed up, but he never bothered to tell anybody that he had an arm missing. He had been amputated.
You told me about this. Yeah.
Yeah.
You told me.
And there's nothing, he's in school. I mean, there was nothing in the school that said you had to have two arms.
Correct. I mean, yeah.
Did y'all change that? It wasn't her, but
No.
do you know if they changed that or you added it in yours?
well, I think you know, everybody's got where you need to be able to lift so much and push and pull, and you know, that kind of stuff.
All limbs. I think you should have a thing on your application that you must demonstrate that all limbs are still attached and function.
You got to be able to use two clamps at once.
Well, yeah, two clamps. I mean, I had somebody that they graduated and then they came to work and they couldn't use one hand. You know, they had some kind of accident and their thumb, they'd torn those tendons, and
Oh, no.
it was chronically. And I was like, "How did you get through school?" And you know, just a little grin on their face. And I was like, "Oh my God!" And it took, you know, about 6 months, and we figured out a way for them to be able to pump with just one hand, you know, double clamp and get, you know, wean. But I don't know how they ever got through school. But they did.
It can be done. I mean,
You know, if I
yeah.
had long-term disability insurance, I swear I'd put my hand down in the garbage disposable and turn it
No,
on.
don't do that. No,
I would
you
do it.
wouldn't.
I would
no,
do
you
it.
wouldn't.
Deb,
No.
I love you so much. Yes, I would.
I love
I'm
you too.
I'm ready to retire,
love you
Deb.
too.
I can't do this. I can't do this shit anymore. I just have to wait until Tabby gets here. I just can't do it anymore, man. They have been beating me up. And it doesn't matter
I'm
what's
sorry.
going on with you. You could be dying and they're still calling you for cases. You literally. You could be, you
Oh
know,
my God.
mid procedure having to do a huddle for an NRP.
Oh my
It's pretty crazy.
Well, you got a great team.
I do.
And I don't
We
know
are
who's
lucky.
there, but tell them everybody
Samir.
hello. And
It's
hey,
Samir.
Hi.
See, there's my colleague right there. That is a rock star.
Dude, he
That-
is. This dude, let me tell you something, man. You know, but I mean, I can't, this is hard for me to say, but I've really grown attached to the dude. He's extremely intelligent. He's got so much experience. He's a very hard worker. He's very positive. He's always smiling and laughing.
Yeah, he's got good energy. He's got good energy.
And
And he
Thank you.
keeps it real, you know.
He
He's
does.
gonna, when you're not doing, you know, I just love and admire and respect him so much. He's been a wonderful friend and colleague for many, many years. And he's good. He's just, you know, we all need to aspire to be more like that.
Yeah, he's Samir, and he actually I hired him based on Lindsay, telling me you really have to hire him. You really have to hire him. You really. And I called him up and said, hey man, would you, you interested? Dude, it was so easy. If I'd have known it was that easy, he's like, yeah, absolutely. I said, damn, okay, sure. I guess, yeah. Lindsay must have said something nice about me too. But
I know what I want, so
it's been great. He's been a tremendous asset to this organization.
Nice,
But
very cool.
thank you again for being. You're closing out the old studio and the new
There
one.
you
I
go,
need you to
see?
come up and see it. It is
I'd love
going to
to.
be, dude. It is built like a studio. It actually looks like a. It is built specifically for that purpose. In fact, it's such a studio that we could rent it to people that needed a studio. It is a studio. That is what it
Wow.
is, a studio.
it's not a
And
garage
awesome. Yeah, I'll have to
conversion.
come see
It's not a
it.
garage convert. No. Oh, I think I think you're going to be so impressed with it, and I think you're going to really love it. It's got a enormous. The green screen is twice as big as the one we have here.
Oh, cool. I have to get Carrie out there. She'll love it.
I
That'd
wish
be
you'd
cool.
bring her. I really do. I wish you
Oh,
would
she'll
bring her.
love it. I'll bring her out there. That'd be fun.
Well, I'd like for you to come see it. I've invited our audience, people that want to come and see the studio inside and what it really looks like and be there while we do these, because we'll be able to have very small, but we are going to be able to have a small audience that can be there and be much more comfortable than here and really be able to see the program as it's being
But
done.
is it in the same
In
location
this-
or?
no. It's much closer to the hospitals. It's going to really help us being able to get some of the other content experts to be able to come in and do programs. So it's like
Nice.
15 minutes away from the hospitals as opposed to 40. Right now we're 40 minutes away. So that's
Yeah.
80 minutes. That's almost a full hour and a half of just travel
Yeah.
over versus 30 minutes of travel, right? That's a big
Right.
difference.
Right.
Yeah.
Yeah, that's huge.
I
It
think
is.
so too. I had, but this worked for the beginning, and even the infrastructure, the stuff that we're providing, the way the lights are being mounted, the way the cameras are going to be laid out, just everything. I think you're going to look at it, you're going to go, wow, this is definitely a studio. It's going to just be so different.
That's awesome. Very
All
cool.
right. Well, I'm looking forward to it. Stay safe.
Okay.
Thank you so
Oh,
much
you too.
for.
Take care. Appreciate you.
I can't wait
Bye,
to
Deb.
talk to Luke. He's going to give that AI presentation for me when we. In fact, I might have him try to do the first one, as a matter of fact, and along with you, that was there at the Texas Heart meeting. I had.
Oh, isn't he awesome?
He is
He's a really nice fellow.
He's a
So,
super nice guy, and
He's so smart. Oh my God.
he
he's
is
so
very.
smart.
We really needed him in this industry. It's kind of sad that he didn't get that opportunity, but
Isn't that crazy?
it is. But he is.
He's doing cool stuff though.
I know, but he's a super nice guy. But I think that as we we'll continue to do these programs, and I think that PerfWeb, we're getting more recognized now. I think we're eventually we're getting some momentum now.
Did you tell her about the dollar you earned?
Yeah, I earned $1.47 from YouTube because they're monetizing our programs now. They do advertisements before the program starts.
He's almost there. He's almost there.
So you made $1.47 and you spent $5 million. So you're
Yeah,
good.
that's okay. Well, it catches up.
You're
It
still in the
catches.
red by 4,900,000.
Yeah, it catches up eventually. It catches up eventually.
Hey,
Okay.
you got to start somewhere, right?
Yeah, gotta start somewhere.
All right, all right. Well, you guys be safe. Take care of you.
Thanks,
Talk
Deb.
to you
Bye,
later.
Thank you
Deb.
so much. Bye-bye.
Bye.
Bye.
Okay. Oh, I was gonna say. Okay, we're out. Okay. So our last program for
Last
this
one.
studio,
Yep,
and we got a picture.
we
We
do.
got a picture. We got a picture. David, can you stand up and get a picture?
Am I gonna send it to him?
David, come
I
on.
sent
will
it to you.
please?
I sent you the
did. You sent
picture.
it. David, please. Oh,
He's
God.
a hard no.
Nope. Nope.
Nope.
Can you show my crying baby?
There's a
You can't. What?
We need some kind of send off, David.
Here, hold on. Let me see if I can do it. Hold on. Let me see.
I got
Let me
like
share
the
my
top of
screen.
David's
I'm
hat.
gonna share it with my phone with the iMac. Okay. And then let me see. Hold on. And let me go to. Oh hell. Let me see.
Look at your text messages.
Oh yeah. It's David. Yeah, that's right. Let me see.
Is there a crying
David.
baby?
Yeah, here it is.
Oh,
okay,
yeah.
here it is. Okay, but I have to start it and don't put it up yet. Let me click it and then I have to pause it. Okay. Okay.
This made me
Okay,
laugh.
ready? Okay, now you can put
You
it
sent
up.
it to me too.
All right, here we go. There you go. We're going to be doing some more of those memes. Do you have any ideas? Let me know. All right, everybody. We'll see you at the new studio. We're going to be skipping July because that's going to be our moving. It'll be sometime mid to the last half, mid to the last half of August when we start back up again. We'll see you then. Anybody that had a problem, don't forget, reach out to me. We will get it taken care of. Again, I'm so sorry. It was, it's on me, and it is what it is. I can only apologize and tell you that I'm going to work really hard to not let that happen again. We'll see you all in August. Bye.
Bye.